managing risk factors. So statins, these folks are going to probably want to be on a statin, right? So first thing we're going to do, if we haven't already done it, they're going to do it inpatient, is get a cholesterol panel, and then we're going to target usually our LDL pretty aggressively. Does anybody remember our LDL goals for prior stroke patients? Or do you guys talk about that stuff? Yeah, so it's actually, new literature is 70 or less than 70, which is nuts. So if they said less than 90 in farm and you tested on it, rock on with your bad self. I actually had to check it out this morning and it was less than 70. I was like, that's low. That's like eat a cheeseburger, go get your blood drawn, and you're already popping 150. So anyway, so we want to keep it low, right? So we want to keep it low. And you guys remember learning about, why is that? Is cholesterol important?
Yes.
What is cholesterol important for? Cell integrity, cell wall integrity, all that stuff. Too much of a good thing is a bad thing, right? So your LDL, and we target LDL, VLDL, and HDL, but how many cholesterol types are there? There's like hundreds, right? So people are always like, if you get into some of these wellness clinics, they'll be like, yeah, Western medicine only tests 3, we'll test the next 20. Rock on, dude, whatever you gotta do, man, if that's what you wanna do. But for us, the enemy here is gonna be LDL. We want a lower LDL and a higher HDL. So the folks that are taking, the molecules that are taking cholesterol from the liver to the cells, we wanna quiet that down. Our HDL from diet and exercise, the ones that are bringing it back to destruction, let's bump up those numbers. Those are rookie numbers, right? Nobody got that one? Okay. All right. All right. So AFib is definitely a high risk factor. So if you have that fibrillation of the atria and it's just doing this all day, you get congealed blood and it can eventually cause a stroke. So if they're not on a anticoag, they need to be on it. So AFib, how do we diagnose somebody with AFib? I'm not trying to be insulting, right? So EKG, right? So EKG usually come in dizziness, syncope, lightheadedness, fatigue, right? I throw on an EKG 12 lead and I'm like, do you know you have AFib? Plus or minus RVR, and I'm like, this is exciting, right? So the rapid ventricular response, just put them on an anticoagulant. If it's RVR, we can control the rate. I don't worry about the rhythm, but I'll bring them in for a check with the cards. But bottom line is I need to be usually on, did they talk about that? Yeah, so usually Xarelto or Eliquis, they're gonna go on those, but yeah. Anyways, I'm not gonna test you on that stuff. Good, so remove the clot if there's clot there. So lipid lowering therapy, oh look at that, it said 70 and I put LDL less than 100. So it's changed, don't worry about it, I'm not gonna ask you it. I was curious about that, slide's a little outdated, so. And someone fact check me if you don't mind, just give it a quick Google search. I'm just curious what the LDL goal is for a prior stroke patient, and I'll keep moving, but just let me know, because I saw this morning and I didn't think that was right, and I thought I read 70, but I just forgot that I talked to you guys about PFAS, and it was 3 seconds ago, so you guys gotta check it. Anyways, all right, smoking cessation, without a doubt, right? So drinking, any drugs, stuff like that, right? So good, and then we'll talk aneurysm. Anybody find it? Was it right, wrong, indifferent? It was 70? Okay, I don't know why it says 100, so. All right, know thy slide, right? Sorry, my bad, but it's definitely 70. I thought I checked that this morning, right after I brushed my teeth. Nah, my tooth is this. All right, aneurysms. So what is an aneurysm by definition? Yeah, it's like an outpouching of a vessel. A weakening of the vessel, right, causing an outpouching. Usually congenital, it can be secondary to increased pressure. So we talked about pressure causing issues against that atherosclerosis. But if it's hitting it the right way and that pressure keeps hitting it, it can also cause an outpouching, which can cause an aneurysm. Is that a problem? Yeah, it's a problem. It's a weakening of the vessel, right? That it may pop, it may rupture, or it may do something else. We're not going to talk about dissections, which I don't know if you guys talk about in cardiology, but can also kind of split between the lumen of the vessel and cause other issues. But we're just going to talk about strictly what happens when it pops in your head. It's not a good day, right? So it's usually a hemorrhagic stroke. So, right, so usually comes with increased intracranial pressure, Valsalva, coughing, sneezing. So anything you do, right, keep kids being dumb, sitting there. Everybody used to just like hold their breath all they could and increase their pressure until they turn red in the face. Whatever, be careful. You're at a higher risk for an aneurysm. So, ones I worry about is older folks so your older folks that are on chronic opioids that are constipated. Those are ones that I'm always on the lookout for a parenchymal bleed is on like, where you're straining on the can, right? Like you couldn't go and you pop the vessel. It happens. It's nuts. But anybody remember who famous that happened to? Yeah, supposedly Elvis, right? That's what I was thinking, but I don't know if it's true or not. All right, what is this? This is arterial bleeding in the CSF, right? Blood is noxious to the brain, so brain needs blood, but it doesn't want it to touch it. So get off of me, right? Spreads throughout the CNS, or central nervous system, excuse me. You get elevated intracranial pressure, leads to coma, which then leads to death, right? And we'll talk about diagnosing a coma versus death next couple minutes here, actually. It's coming up. All right, it's typically short, so you get arterial spasming, right? So you get rebleed. So usually it bleeds and it clots, and then bleeds again and clots again, and bleeds again and clots again. And what is causing that rebleeding and clotting? What do you guys think? So I stand up here like a jackass and I just increase my ICP in front of you guys and turn my face right and I pop a vessel. Let's hope I don't do that, right? So it bleeds and it clots, right? Because I probably fell down. Now I get up, my heart rate starts going, my blood pressure goes up again. It removes that clot because I move it around. Maybe I go up a flight of stairs. Or maybe I do something to get aggravated. So those are the type of things that can cause rebleeding. Usually secondary to moving though, like after you fall down from the initial bleed. But all right, vasospasming can be very painful. We'll talk about that in a second. So what did we talk about earlier? So sentinel or warning shots, sentinel bleeds or TIAs. That's why I aggressively treat those transient ischemic attacks as a full court press stroke workup, because it could be our only lead to like, hey, this could be a precursor of something real bad coming, real ominous. So, all right, sentinel bleed, just by they may have that warning bleed. I'm not big on numbers, but you can see there almost 50% have a warning bleed of an aneurysm. So sudden or severe headache, typically 6 to 20 days before the big one, 6, 7, right? I don't care, like 1 to 3 weeks. You saw me do that? Do you like it? No? 7, all right, some statistics down there. So headache, we got to be on the lookout for headache. What do you think this headache is going to feel like for these people? Yeah, right. So pathognomically, the worst headache of my life. Like if they're an iPad grab, they'll be like, I have a thunderclap headache, and you're like, holy shit, but what? You're like, oh my god. Like, but they say it's the worst headache of their life. So again, sudden onset, severe pain, worst headache of your life. Let's rule this out, and we'll all go home and feel happy. So you get different types of intracranial hemorrhages. You get your subarachnoid and your intercerebral hemorrhage, which we'll talk about. And those are just by definition based on their anatomy, to be honest with you. So subarachnoid hemorrhage, mostly referred to as a ruptured cerebral aneurysm. 45% dead within the first 24 hours. How do you like those numbers? Yeah, I don't know. So just have a high clinical index of suspicion, worst headache of your life. Like that's where we get kind of jaded as providers. And I don't want to tell you guys like be jaded early, but all right, where do I go down the road of kind of camping back? So if I come into you guys, let me just ask. I'll pull the class instead of. So if I come into you guys, I'm smiling. I have a big smile. I'm playing on my phone. See you in clinic, and I'm like, this is the worst headache of my life. 10 out of 10. What are you gonna do?
Are you drunk?
I'm not drunk. I had a Chardonnay, what of it, right? What are you gonna do? Yeah, so you're gonna quantify it, you're gonna do your physical exam, but I'm really trying to pigeonhole you guys in experts. You're like, we're gonna do a neuro exam, we're gonna, right. If your answer is send them to the ER to get scanned, I'm not mad at you, honestly, and I'm teaching this neuro class to you. And if you can justify it, they said it's the worst headache of their life and you don't wanna take a risk, that's fine. Medicine is about taking risks. Sometimes you don't want to be risk. You want to be risk averse, and you don't want to be like, this kid playing on his phone, smiling and laughing. I don't know what his 10 out of 10 is. I would probably laugh at him. In the ER, I'd scan him and laugh at him, right? So it's easy to say that. But so we get into this thing downstairs. There's a senioroscopy. It's like headache, it's a migraine headache, and they're like, it's very superfluous vernacular. They're basically like, oh yeah, it's a 9 out of 10. It's close to the worst headache of my life. And you guys are just trying to mess with the students. Stop doing that. Like, if it's the worst headache of their life, it's the worst headache of their life. And then you'll get into all the other stuff, quantify it, front, side, left, right. Does it radiate? Photophobia, phonophobia, nausea, vomiting, all that crap. You'll talk about that. But if they're going to put that in there and the student's going to turn to me and say, I would like to stop this exam and send them to the ER because it's the worst headache of their life, I'm going to pass them. And I'm going to say, 100%. Like, all right, so now let's pretend it's not. It's a tension headache. What else would you do? I'm like, stop wasting time. But I hate when that sort of thing happens, and we said, so if somebody comes into me, and in my headache, in my dot phrase, insert headache, right, and I change everything, I have in there, denies worst headache of their life, denies nuchal rigidity, afebrile, all these red flags. But if they say it, we're going hard in pain. Like, you're going to the scanner, man. So, anyways, and why do I say that? And again, I let off and not trying to jade you guys. I say that because 45% die within the first 24 hours. Highest incident, 4th, 5th, and 6th decade. Anybody else in their 40s here? All right, it's coming for us, buddy. Yeah, it's coming for us, right? So, yeah, even a higher propensity, right? So maybe you're like, oh, all right, 19-year-old, they're laughing on their phone. All right, BS, right? Which I don't ever recommend calling patients complaints BS. But if you come in, you're 40, 50, and 60, and you say it on your phone, I don't care. Keep going. So, little soapbox for you. So. All right, 2 common aneurysmal types. So you get your saccular aneurysm, which is by far the most common, also called a berry aneurysm. You'll hear that terminology a lot. A patient had a berry aneurysm. Anatomically, it's at a bifurcation. I talked to you guys about the PICA and the cerebellar portion at that first bifurcation. This is similar to that. It's just in a different part of the brain. So you guys can see there. Do not memorize this. You can look it up if you get pimped on it or asked. But it's at the base of the skull, the cervical willis, first division of the MCA, which is your middle cerebral artery at the Sylvan fissure, whatever that is. So just know that there are 2 types, and saccular by far is the most common. Okay? Gotcha. So it can be an eruption from either the anterior circulation, which is most common, or posterior, so mostly in the front, right? 4 main hallmarks: headache, syncope, nausea, vomiting. Often referred to as worst headache of the life, or thunderclap headache. So if you're taking your test, okay, I might throw a thunderclapper up there. Thunder, thunder, thundercats. Nobody? Nothing? All right. Oh, anybody? I think I just crossed streams there. I think I went Thundercats and He-Man, which it's a problem. It's a problem. Never cross the streams. All right, that last 2 minutes I just spoke like outside of my body, so we'll just pretend that didn't happen. All right, what was I gonna say? I can't remember. It's awful. Hold on, I'll come back to it. They say look up and right. I'll come back to you. Nope. All right, pathophysiology we already talked about. So this is active bleeding. So subarachnoid hemorrhage. It's a hemorrhage by definition. So increases ICP. We already said blood on parenchymal tissue is noxious. It's not good. So kind of gets that increased ICP, coma, death. You can see there are lots of conscious 50% of your patients. Cool. You may see these subhyalinoid retinal hemorrhages. Okay. I don't know if you need that to make the diagnosis, but that's pretty cool. It may be bleeding into their eye, which, I mean, it's not cool for them, but it'd be a neat finding. So, again, worst headache of my life, severe headache. You can get focal pain behind the eyes, retroorbital pain, stiff neck from leakage of a small amount of blood. So, again, any kind of neck pain should be a red flag, either for subarachnoid and or, we haven't talked about it, but meningitis, meningitis, encephalitis. So. You can also see a third, cranial nerve palsy, diminished light reflex, or pupillary dilation. But I tell you, usually these folks look sick. So with the subarachnoid hemorrhage, they look sick, they look pretty miserable. So this is an abrupt, severe headache with a ruptured vessel in their head. So I already said it, we'll say it again, worst headache of my life, loss of consciousness, they get transient LOC, about 50%, confusion, stupor, and coma. They get vomiting, key factor, new onset of sudden headache. So bleeding doesn't last all that long, and the pain is quite severe, right? 2 days, very slow resolution of symptoms. You don't have to remember the timeline. But clinical findings, what's going on? Elevated BP, is it compensatory effects? They got a hole in a closed loop circulation system, so what's going to happen? It's going to try to elevate and compensate initially, right? So if too much blood gets out in there, unfortunately, it'll go all the way down, but let's not wait that long. That would be pretty damn impressive for that size bleed. You get hypothermia from meningeal irritation, nuchal rigidity. You can see your neuro findings, typically non-focal, right? Initial exam, what are we going to get first? Yes, this is the one we're going to see active bleeding. So what is it going to look like? It's going to look white, right? So like a white splotch on there. So this is the one, this is why we do that non-con CT ASAP, is to rule this out so then we can start thinking about other stroke causes, maybe ischemic, other things, right? But if I do this early, worst headache of my life, you come in and see me, I spin your head, and I see hemorrhagic bleeding, right? They are no longer a candidate for what? Thrombolytics, out the door, walks. Just remember that. I know it's pretty simple. It seems simple, but just please remember that. Okay. Something to consider. All right, what is this going for here? Yes. So study of choice. If you see no blood, so it may be a microbleed. This is kind of interesting to me. And some of the bleeding, it may be so small that you'll see it in the CSF a little bit later. So if it's positive for subarachnoid hemorrhage, you'll do a CTA, so you do a CT angio. If it's negative, right, you can look for an LP and look for xanthochrome blood in the CSF. If you're still worried about it, something doesn't make sense, right? I did a CT, I did a CTA, everything looks good, I want to do it. Now you're working yourself down almost like this LP thing where we talk nuchal rigidity, worst headache of my life. I'm like, I got a tap, and this could be meningitis. And you may come back and see a little bit of blood in there. It's still maybe a slow bleed going on. So just something to consider in your differentials. And then our labs, you guys are going to check everything, right? So when they come in, really before we do any type of LP, we'll probably get labs at the same time. They'll be cooking. It's not going to slow you down. And I hate the term, but I'm going to use it. You're going to get a shotgun in the labs. You're going to check all your CBC, CMP, probably get a CRP, EKG, cultures. Like, these folks are sick. If you still don't see anything and they're still sick and they're not getting any better, admit them, right? So admit them, MRI, MRA if you're not going to get it. I'm talking specifically if you're at an ER. Like, I don't know what's wrong with them. I cleared everything. It's not X, Y, and Z. They're still pretty miserable. 10 out of 10 pain. I tried X, Y, and Z and they're not getting any better. Admit, intractable pain, can't fix it. Let somebody else work on this. But you did your due diligence and you worked them up within your capabilities. So. All right, treatment. And again, we've talked about bleeds a little bit. So absolute bed rest, quiet environment, no stimulus. We just want these people to chill out, especially until a neurosurgeon gets to see them, right? So elevate the head of the bed, mild sedation, analgesics for pain, stool softeners, no platelet impairment. Watch out for your hyponatremia, vasospasms, right? So they're going to need an angioplasty, a cerebral angioplasty, some stenting or clipping, right? So they're just, bottom line is, we need to make sure we're preventing them from getting any worse or protecting them until we can get them to neurosurgery. We're not doing we're not clipping perianeurysms. Although you may sit on or scrub in on one, which would be pretty neat. But we're not stenting or clipping them, but we need to prevent that blood pressure from going higher, from them vomiting, from them seizing, control their pain, that type of thing. So, all right, clipping of the neck, we just kind of said it. Just know that's out there. If you're going, if you have a surgical rotation and it has, subarachnoid repair, just review it, Google it, look it up, see what your prominent anatomy is, but I'm not going to ask you too much about that. So. You see the prognosis, 20 died before the hospital, 20 died from bleeding, 25, and then 20 died from rebleeding. So this is a tough one. Complications from subarachnoid, right? So cerebral ischemia, acute hydrocephalus from the clot, bleeding from the rupture, increased risk for future normal chronic hydrocephalus, increased water, use fluid inside the ventricles, okay? Let me see here, anything else I want you guys to know? Yeah, so the major cause of delayed morbidity and mortality, cerebral ischemia due to that vasospasm. So that bleed, rebleed, and that spasming, okay? All right, and then lastly, we'll talk different type of bleeds. So we talk subarachnoid and then intercerebral hemorrhage. So this is more common than subarachnoid, it's just bleeding in different parts again. Groups with increased risk, Asians, African Americans, per literature, per data. Risk factors, hypertension, smoking, alcohol, low serum cholesterol, ASA therapy, and anticoagulation therapy. Low serum cholesterol, but I just told you we're targeted 70 and below. What are we doing? So you had a stroke, and I'm working on getting an ischemic stroke, and I'm aggressively attacking your LDL to try to be below 70. And now too low that it's potentially going to be a risk factor for intercerebral hemorrhage. That's not fair. Why do you think that is? Get this man a cheeseburger. His LDL was low. What did we say LDL was important for? Cell wall integrity. So cell integrity or cell wall integrity, if the walls of our arteries are made up of cells, and too low of this is causing a lapse or collapse of that cell wall integrity, that's a higher propensity to punch right through it, causing bleeding. Nuts, right? Not fair. It's just not fair. So there's a balance. So we gotta be careful. So cholesterol is extremely important for the integrity of that cell, but if we drop them too low, which I don't know that I've had that problem, it's gonna be straight up and honest with you. N equals 1 up here, but I've never been like, sir, man, your LDL is too low. I recommend you go to Whataburger. ASAP. Like, that has not happened in San Antonio for me. So, it's usually the other way, like 300-400, holy moly. Hey man, what's going on? What's up? Besides your cholesterol. I don't say that, that's me. All right. This is likely related due to microaneurysms, right? So it may extend into the ventricular system or subarachnoid space, depending anatomically where it is. Signs and symptoms, right? Consciously is initially lost or impaired, vomiting, headache, and you can get focal signs and symptoms as well. So, focal sign findings are going to be dependent on the location. Obviously, that's going to make sense. But again, we go back to say day one when I met you guys, what is your patient acting like? What are they doing, or what are they presenting with? So. Common sites, put them in, thalamus, cerebellum, pons, basal ganglia, I highlighted down there, and I'll tell you why this law is tight now. So that's a classic location of hypertension. So we just talked about all those risk factors, hypertension, smoking, low LDL because of cell wall integrity, right? And now this person has continuous hypertension, or the hypertension, is they're in like a hypertensive emergency or urgency, I would check your basal ganglia area, or just note it, you're not gonna be checking it, but I've seen these a lot. I don't know that any of our examples that I showed you via CT were a basal ganglia rupture, but anyways, I highlighted that for you guys because if you're looking at uncontrolled blood pressure, this is the classic one for hypertension. With surgical resection, what do I say here? Ischemic, fibrosis, local massive hematoma. I agree with all this, so that makes sense to me. I'm going to read it to you guys. All right, symptoms, right, depends where it is, but confined to tissues that contain bleeding, evolve over minutes to hours. Do not begin abruptly or not maximal or onset, kind of difference. This is slower, more gradual presentation. Eventually cause elevated ICP, vomiting, decreased consciousness. So deficit worsens, seizures are uncommon, deficit worsens over 30 to 90 minutes. So just something to consider. So again, imaging, what first? CT non-con, right? So how many people are going to choose CT with con or MRI? Somebody? Okay, I thought you were raising your hand. I'm like, do it, man. That's what you want to do. What do we look for? So it's going to look like bright white spot, which we've already talked about, bright circular object within the brain parenchymal or within the confinements of the skull outside of your dural, subdural, epidural space. MRI, you can see your findings there. Probably not going to stick around and see those, but I'll give you guys a CT scan. If I give you a question on this, I'll give you this exact picture. So you guys can appreciate interparenchymal hemorrhage. You see the midline shift as well. So they got a left to right shift. So this keeps going, where eventually is this person going to herniate? Down, right? So eventually we'll give left to right enough, but we'll start herniating down. When we start herniating down, what happens? It's bad. It's very bad. Okay? So death eventually, we get to the foramen magnum, but eventually coma, stupor, all that stuff. So, all right. Blood pressure in hemorrhagic stroke. So we talked about permissive hypertension and ischemic stroke. If you guys remember yesterday, we're okay as long as you talk to neurosurgery, but by the literature, we're okay for elevated blood pressure within confinements of less than. Do you guys remember your systolic less than? For ischemic, yeah, 220, that's pretty damn high, but we want that collateral circulation. Not for this. This is a bleed, right? So get your targets from usually your neurosurgeon will give it to you on the phone, but just know that 150 between 220, we want to lower that. Slow and steady, right? So I can vasodilate them, nitroprusside. I can drop them pretty fast, but that's going to create another problem too. So usually want to start these folks on a drip. They're going to the ICU anyway, so you do a cardiac drip. You could do whatever the neurosurgeon tells you to, but I just want you guys to know that for hemorrhagic, it's completely different with management of blood pressure, excuse me. Okay, and you see if it's greater than 220, right? So then we want to lower to 140 between 160 and low and slows. For your subarachnoid, lower than 160. So just remember like 140, 160 is a good target, and just bounce that off your neurosurgeon. Hey, sir, ma'am, if you're in the ER, like, hey, sir, ma'am, I got this patient. Let's say they have hemorrhagic stroke. The head's elevated, got some labs are done, CT confirmed it, I gave him X, Y, and Z, like, I'm gonna maintain the blood pressure at 140. They may be like, oh, I want it 150. Like, roger that, 150 it is. And they probably have their own reasons, but. All right, monitor signs for cerebral hyperperfusion, stop all antiplatelets, anticoag or reverse, that should make sense. And then hypertonic saline. This is one I think I misspoke yesterday because I was either off in la la land when I was talking about ischemic strokes. But for your hemorrhagic strokes is where you want to get into like your 3% hypertonics, and that should make sense. So for a salty solution that I'm giving the patient, what's that going to do for fluid outside the vascular system, right? So it's going to pull it back in towards me. So if they're bleeding out into tissue, I can give her a him or her a hypertonic saline now, because that'll kind of pull some of that extrastitial tissue interstitially. Does that make sense? I believe I misspoke yesterday. I kind of hallucinated for a second. It doesn't make sense. You look confused. What you got, man?
Target research.
Yeah.
Wouldn't that raise their pressure though?
It could. That's why we're balancing, but it's also going to take some of that extrastitial fluid interstitially. It's a game, man. So I would say the time. This is a tough one, but if you're out by yourself and you're managing this patient and it's a delayed evac, it's something I'd consider doing. But if the neurosurgeon's not telling me to do it and they're upstairs or next to me, I'm not, like, you can do that yourself. What else could I do to increase some of that ICP? Or decrease, excuse me, yeah, see it. Mannitol, right? So you could give them mannitol to get some of that fluid off. Yep, yeah, so you can do a lot of things. I would say it's there, just be aware of it. If you're out by yourself and you're making the call, Ford in World War III and you're in Foxhole, I'm your patient, you can try it on me, I won't be mad. Typically speaking, if you're talking to a neurosurgeon or something before that and they want it, I'll just defer to what they say based on their specific requirements. All right, at a very minimum, blood pressure, right? Head at 30 degrees, neurosurgeon consult ASAP. Kind of just goes over what I just said. So consider, if you delayed evac or you're out in a rural hospital or the side of a mountain or in the death or whatever, just hallucinate with me. Consider sedation, consider mannitol, hypertonic saline, or tracheal intubation if you need to. Consider. It's just out there for you. All right, vascular malformations we'll go over real quick. AVMs, DVMs, angiomas, telangic stages, and then we'll kind of. So these, why are we talking about congenital abnormalities after we just talked about bleeds? Because these can set you up for a bleed, right? So if they're there and you have a congenital abnormality, you have something that's going on, let's say do a CT, you guys come in, there's not active bleeding, but you've got some sort of AVM or DVM, we gotta work that up. We can't just be like, oh, didn't pop yet, like, ooh, victory. Like, I'm probably gonna send you to a neurosurgeon for a non-emergent consult, but you need to go see something. So. All right, AVMs are atriovenous malformations, so abnormal blood vessel communications, typically within the MCA or middle cerebral artery. Arteries that empty directly into arterializing veins. So if you guys remember, arteries, arterioles, capillaries, venules, veins, you guys remember that stuff from anatomy. So it's just a little malformation here, like we just skipped a few steps. So there's no normalizing capillary bed, and they have an abnormal gliotic parenchyma. I don't care that you know that, but essentially this is a congenital shunt between arteries and the venous system. So what's the problem? What's the problem? So I don't have that middle fiddle. I just have like big tube, medium pressure, right? So pressure convergence. I don't know. You can get into some thermodynamic law. No, it's just pressure. Just increased pressure that could be a precursor for a stroke. God bless you. So you guys can see there, maybe hard to see, but retinal hemorrhaging. That's not hard to see, but you can see there. That's an AVM, right? It's a massive irregular tortuous vessels over the left posterior parietal region. So you have to kind of squint to see it, which looks like, if you look at all the other tissue around it, all the sulci, the vessels, everything looks normal. It just looks like someone threw almost like a bag of worms. Why does that keep coming up? But threw like an earthworm on his head, and I gotcha, right? It's all like squiggly, tortuous, redundant. That's where you get that increased pressure. So. Well, I think we just said this, but arteriovenous malformation is what it is. This is an easier one to see. Everybody in unison now. What's going on? No, it's just the black mold we filter in for you guys. Don't worry about it. Oh wait, I'm breathing it too. All right, so this is congenital. We kind of talked about high blood flow or pressure. Okay, we'll go to DVMs. So highlighted for you guys there. I might ask a question, just talk about it in review, but just for now, for this morning. So this is the most common brain vascular malformation. Oh, excuse me, spurred again. So these are anomalous veins. They're morphologically different from the brain parenchymal. So you have one or more central vein draining that's conspicuous, maybe dilated into a varix or varices, excuse me. So again, what is that? It's a tortuous dilation of veins, a tortuous, just redundant kind of venous structures, almost like collapsing upon themselves. So, how would I really know the difference between an AVM and a DVM? Probably your imaging, to be honest with you. And then, both of these you're going to refer out because they're going to be a precursor for strokes. All right, cavernous angiomas, right? So this is the relative compact mass of sinusoidal vessels. They're packed closely together. They have no intervening brain parenchyma. They're well encapsulated. They're probably not going to do anything for these. They're just going to note them. I just want to let you guys know they're there. So again, telangiectasias. Now we're talking capillary malformations. So this is a true capillary malformation. They're not going to do much of these. We're just going to keep an eye on them. So anybody know what a telangiectasia looks like? Spider veins. Yeah. So you'll see them. You guys haven't had derm, so it's not fair to ask, but sometimes you'll see them on people's face. You'll see like a basal cell with a telangiectasia. It just looks like a little, like, almost spider little area. I know I'm not doing any justice doing this in my fingers. You guys like, is he casting spells again? Yes, I am. But you can see them dermatologically, and they can also be in the brain. If they're in the brain, they're probably not going to do much because risk versus reward, right? So, okay, if you got one, you can put them on a medication to reduce seizures if they have seizures or seizure prophylaxis. I probably won't start them. I'll send them to neurosurge. Surgery if it's indicated, interventional obliteration, so they can go in and zap these things, or radiotherapy, just FYSA. Okay. Everybody all right? Telangiectasia. Yeah, I like that, man. That's good. That'll be my new spell. Speaking of, I'm waiting here. This is coming right up. But I told you guys I was scrolling the internet. I just got to figure it out. I think I'm addicted at this point. Like, I got to find a way to break this. But yesterday, AI is funny. Like, they find one thing that you stay on for a couple seconds, and next thing you know, you're flooded with, like, I'm like, dude, what? I don't care about this. I don't know. I saw some dude, and he was throwing something at another guy. He was yelling, lightning bolt. It's probably old. But now I'm in this, like, whole thread where it's just a bunch of dudes dressed up fighting with, like, Nerf sticks and throwing shit at each other. And I'm like, I don't know what's going on in my life. I need to get control of it. Does anybody know what I'm talking about? So I thought about it. I thought how it would go over at the Med COE if I brought in, like, little packets and started hucking at people. Lightning bolt, lightning bolt. My man's just down with the lightning bolt. All right. Let me watch this. Do you guys need a break or just want to rock and roll? This is a short one. What's that? You want to watch lightning bolts? Oh, what is happening? My thing's having a seizure here. Oh, calm down. Lightning bolt, yeah. Yeah, so last night I was in there and I was watching these dudes, and I mean, it was like 5-on-5. It was all mayhem. And they had like pool noodles and were like stabbing each other. And I gotta tell you, like, the integrity of the team was impeccable. Because, like, they'd be like, oh, you got my arm. And they'd be like, all right, I'm out. And I'd be like, bullshit, I'm fighting without my arm. Like, is this gonna stop doing this, or what do we think? I can't watch it like this. I can't rightfully ask you guys. Let me give it a second. But one of the dudes was like, this is what really got me. Probably stayed out of line with me, but he was like, they were going through their little fight and they were throwing lightning bolts and whatever at each other. That's visible. And the guy was like, have you guys ever been deployed downrange? And I'm like, there he is! There's the guy! And he's like, this is just like, a 4-man stack in a room. And I'm like, Hang head and shame. Alright, we'll watch. I thought this was neat. It's got no volume, maybe. Let's see if it does.
Soldiers are often exposed to traumatic head injuries in the battlefield, especially during an explosion. Blast injuries are caused by the impact from a complex pressure wave generated by an explosion. This can result in a more complex traumatic brain injury. In this scenario, 3 soldiers are exposed to an explosion. The first soldier has fallen to the ground. He is not moving. The second soldier is a few meters away, lying still on the ground. The third soldier is feeling dizzy, but seems okay. He calls for help. It takes more than an hour for the 2 wounded soldiers to reach the military hospital where they get their CT and MRI scans. Although they have suffered a concussion, the doctor can't see any signs of brain injury. Because of the negative result, an injured soldier can wrongly be discharged and even sent back to the battlefield. What if there was an easier and faster way to detect a brain injury? Let's look at another scenario where the soldiers had many cortex strips on them. Using a person's saliva or urine, the kit detects biomolecules released from the injured brain cells. The first soldier, who was not moving and was not wearing a helmet, was quickly given a strip in the mouth and tested positive. He has a concussion. The soldier wearing the helmet, but who was lying still on the ground, was also given a strip. However, he was tested negative and does not have a concussion. The third soldier, who seemed okay, decided to take one himself. To his surprise, he too was tested positive and therefore had a concussion. Cortex strips should be an essential part of any military first aid kit. They are effective for rapid and reliable detection of brain injury. They can resist harsh weather conditions, including smoke, dust, and rain. They can help prioritize the evacuation order and free up hospital facilities, such as CT scans for more serious cases. Soldiers who pass the test can stay in the battlefield and continue their basic military assignment. If undiagnosed, soldiers with brain injury are exposed to high risk of worsening their medical condition, which was the case with more than 370,000 American soldiers returning from big military operations. Cortex heading.
Alright, what do you think? I don't have any of that. So that's what I would ask too. I was honestly going to ask you guys if anybody's heard of these being used out there, because I have not. That's what happens if you go down the dark web. This was in Finland, so I don't know what their success rate is. It's not approved over here, but it was interesting. I thought it was certainly interesting. I don't know, I think it has if it's high sensitivity specificity, you think it has a play in our arsenal? Maybe? Man, it's misleading questions. I don't know much about it. I would want more information too. I'd like to see some of the studies, but yeah, I was searching it and I was like, let's get a good concussion. I put Army concussion and this thing came up and I'm like, what? Interesting. Okay. All right, you guys think you're gonna see concussions?
Yes, sir.
Where are you gonna see concussions? Sure, it's anywhere humans can go, right? So, blast injuries, next war, PT, right? So, combatives, basketball is a big one. Flag football, which is not flag football, is a big one, right? You get a bunch of especially, you know what's crazy? Is if you're like in an HHC brigade, which you guys will all be attached to, is some of the older folks get there, older Army olders, like, no offense guys, but like 30s or 40s, like I'm Army Unk. But you get a bunch of 40-year-olds out on the field to play flag football, and you just all of a sudden think you're like Deion Sanders, like, not good, not good. Like ragdoll, hospitalized, concussions, blowing out ACLs, like that's where they all come to you after. What is going on with the 3 shop? Like, you guys are all like senior NCOs, senior officers, only play flag football. So, all right, so keep an eye out there. And what do we use in the military for concussions? To diagnose them. My arm just fell out of the socket. What do we? Yeah, a mace, or mace 2 now, but which is kind of good, kind of bad. What do you guys think is good about it?
Consistent.
It's thorough. It's consistent. What's bad about it? You can memorize it, right? It's consistent, right? So it's a double-edged sword. But So we'll talk about kind of, and we don't use that outside, in the civilian side. We actually don't really have a good tool other than a Glasgow coma scale and your clinical suspicion, to be honest with you. So. But you can take that with you. It's part of your practice when you go. They want to do a MACE exam. Have all your LPNs, LVNs, medics out there on the civilian side and look at you and be like, you want me to do what? That's not in my contract. I'm not. Anyways, all right. Anybody want to do a shoulder exam? See this thing pop out? That'd be fun. All right, TBI is very common, right? So bimodal distribution, highest risk in younger kids and older folks. Makes sense, right? So younger kids, more active, older folks, they're just old, they fall. Does that make sense? So we talked about Parkinson's yesterday, dementia, those folks fall, unfortunately. Younger kids are probably doing more sports, more activity, riding dirt bikes, riding motorbikes, playing street hockey, whatever it is they're gonna do. So definition, sure, alteration of the brain function caused by an external force, and characterized by the following: any loss of decreased consciousness, any loss of memory from events immediately before, retrograde, or after post-traumatic injury, neurodeficits and/or alteration of mental status at the time of injury. So how do we figure this stuff out? How do I know if they had a loss of consciousness before, they remembered or don't remember? You talk to your patient, right? So did you hit your head or lose consciousness? I don't know. Do you remember anything before or after the event? I don't know. Let's just assume that's a yes, and maybe do some neuroimaging, probably rule out some other stuff, but if they say, yes, I remember the event, I did not lose consciousness, I got a slight headache, you can lean more towards, maybe I don't need to scan these folks and just take a look at them and watch them for a little bit. So. All right, what's the mechanism? Should make sense. Head struck by an object striking the head, brain undergoing A cell, B cell. So if you're in a car fast enough and someone brakes and you stop, that inertia, the skull or the brain can hit the inside of the skull, causing microtrauma. So again, how do I know this? You ask your patient, what were you doing? Like, what happened, right? Foreign body penetration or blast, concussive blast, right? So the overblast or secondary blast from an injury or from a projectile or bomb or some sort of explosive, sorry. So most commonly, motor vehicle accident. So motor vehicle accident is by far going to be the most common. So yeah, take a look at this. I know what causes it, but you got to ask it. So. Severity of classification of severity, a little bit of backwards there. Your GCS is the most recognized, widely used method of grading a TBI severity, so we're definitely going to want to know this. Have we been exposed to the GCS yet? You guys had that already? Well, no, so this is new. All right, so I'll keep you guys out of the woods. You're going to have it for emergency medicine. So the grading is going to be applied to the best response, right, that can be elicited to the patient at the time of assessment. So we'll talk about what that means. If they give you a crap response and then do better, we're going to go for the better response that they give us at the exam. So, 3 components: eyes, verbal, motor, and we're going to be graded 3, 4, and 6, right? No, that's not correct. That is 100% correct. It's going to be 4, 5, and 6. I just read what was on there. That's just giving you an example of how you may want to report it. So somebody asked me once, like, why don't I just say GCS 12 instead of saying eyes, verbal, motor? It may give that neurologist or somebody you're talking to some better finite information. So how you derive the total GCS score. I apologize for that. Just to repeat, because I don't want you guys to misunderstand. So it's going to be 4, 5, and 6, and it's just going to go 4, 5, and 6. So eyes, verbal, hands, 4, 5, 6. It's too easy. Unless my dumb mouth spits out numbers like 7, 8, 9, 6. No, it's 4, 5, and 6. So again, total number of like 13 is just less informative, but it's totally acceptable. So if somebody comes in and they're bringing an EMS and they say their GCS is 13, don't freak out and be like, well, I don't know their eyes, it's going to take you seconds to get one. I usually deal with that when I'm talking to neurosurgery or neurology, and I'm like, their GCS was 12, and they're like, how'd you come to that? And then I'll tell them, they'll be like, okay. And they just want to know, okay, so they have a decreased motor capability right now, everything else was fine. So, unfortunately, I'm going to ask you a question. I'm going to give you a question to calculate. So again, I just start from head to toe. Eyes, verbal, motor. So eyes first, 4, 5, the verbal response. Motor is going to be 6. So who gets a 0? Nobody. So if you're dead, your GCS is 3. So if I give you a dead patient on your exam and you tell me it's 0, you're wrong. You're wrong, Colonel Sanders. Right? So, they're going to get a 3, so if they're dead. So just look at that, and then at the bottom here, this will be a little bit important too, because I'll ask you to categorize their injury, whether it's mild, minor, moderate, or severe. So I would know, again, how to calculate a GCS, and then I would know 13 to 50 could be a mild or a minor TBI or brain injury. Moderate is going to be 9 to 12, and then severe is going to be 3 to 8. So, and you guys have heard it before, less than 8. Less than 8 and a big, right? Stick with it. I'm gonna tell you that lady, that basilar skull or that basilar occlusion I had was hovering around at 8, 9. Can we make 8, 9? I think. Nah, that's lame. But I didn't tube her until she started. So she was coordinated and then cerebral posturing. So once she started that, I was like, all right, lady, you're asking for it. So I probably should have done it earlier. I think I was being lazy. Honestly, I didn't have a shocker. All right, the coordinate posturing. Coordinate to the core, right? You guys we talked about this. Is flexion of the elbows and wrists with supination of the arms, bilateral damage to the rostral or midbrain. I don't know, care that you know where it is, but and then decerebrate extension of the elbows and wrists with pronation. Okay, and this is going to be damage to the motor tracts in the midbrain. So this is kind of again a stepwise declination of your patient's physical presentation. Does that make sense? So coordinate, decerebrate, you'll need to know that because again, when you look at your GCS, you're like, I'm just not going to do this. If I give you a motor response, I can ask you like 2 questions in one here, and I tell you that they're posturing to the core, or I say that they have flexion of their elbows and wrists with supination of their arms. You'll know that you need to go with a 3 for their motor response. So, all right, TBI types: mild, moderate, and severe. We just mentioned it. I would like you to know the corresponding numbers. That just kind of makes sense to classify the type of TBI they're having. So, all right, commonly referred to as a concussion or a mild TBI, MTBI. I'm not going to ask. I've certainly had a bunch of these, either playing football, hitting my head, whatever. I'm sure half the class, I'm just going to guess arbitrarily, has probably had an MTBI or a mild concussion. Like, cool, that's aggressive. Maybe it is, maybe I'm wrong, but you hit your head hard enough, fall down the back, smack your head, you get some blurry double vision because you hit your occiput, you may have had a TBI and it's just undocumented. So, anyways, this is going to be the majority of what we see, 79% of all TBIs, minor head trauma, brief loss of consciousness, fully alert, 10 within minutes, and then they could have the following symptoms: headache, dizziness, nausea, single episode of vomiting, underlying single episode of vomiting. So, single episode of vomiting. So if it's intractable, they continuously vomit, then we probably need to have a higher clinical index suspicion something else is going on. So, difficult concentration, brief amnestic period, blurry vision. So typical prognosis is good, right? So good prognosis for your typical concussion syndrome. Yep, got it. You're not wrong. Elmo. Treatment, brain rest, right? It doesn't say it up there. If it does, I'm missing it. So for mild TBI, brain rest. What does brain rest mean, guys? This means go home and sleep. So the brain repairs itself when you sleep. So he's absolutely right. No phone, electronics, no reading, nothing concentrating. Don't try to do your algebra homework or calculus homework. Don't go back on patrol. You guys get where I'm going with this. Just go home and sleep, right? And there's this old adage that used to be, before my time, it's probably what dinosaurs were on, but you never wanted a concussion to go to sleep. Why is that? Why do you think you thought that? Maybe they had a brain bleed and they were going to die. So this is after you see them, right? So I'm not, just be careful what I'm saying. I'm not misconstruing it. Like someone hits their head, they start throwing up, have some amnestic property, they're like, put them down. Like, get your ass to sleep. Here's 100 of Benadryl. This is after we check them out. There's no focal deficit, no neurological exam. Plus or minus, you scan them, everything looks good. You're more confident it's concussion. We now know that they need brain rest. They need to rest and recuperate, okay? That's why people freak out in the ER when I see them, I scan them. You got a TBI. Oh, you got a concussion. Okay. When we say traumatic brain injury, it sounds a lot more scary. You have a concussion. Okay, what do I do? You go home and you go to sleep. Oh, I died? Yes, you will die eventually, but not from this. And they're like, what do you mean? I'm like, yeah, I'm kind of cynical on that. I tell them they have SODS. I told you guys that, right? So I go in and I'm like, yes, you have SODS. They're like, SODS, what's that? I'm like, slow onset of death, 100% fatal, gets everybody all the time. Get it? Like, think about it. I'll be back. We need time to think. All right, when do we image? So I would kind of know those. So again, we talked about, well, going back to this, everybody gets scanned. And I've talked to you my feelings about it, right? It's almost defensive at this point because you never get in trouble for doing too much in the ER. But we also want to practice medicine and we don't want to give our jobs to AI. So have an idea of when you're going to scan somebody. So persistent severe headache. So what does that mean? I gave you a Tylenol. So if you have a mild concussion. Did you sneeze with your arms crossed? That was neat. It was like a genie. So if I give you a gram of Tylenol and I come back and your headache's worse or not any better, that may be your clinical tip. Worsening headache, right? So a gram of Tylenol should help a headache, in theory. So what's going on? I don't know. Maybe I missed something. Right? So I had that 30-year-old, I had the 30-year-old with pituitary adenoma who had a headache, kept vomiting, gave her a headache cocktail, she was getting worse. I don't know what's going on with you. I wasn't going to scan you, you're 30 and healthy, but you just want a trip. Congrats, you're going to the scanner. Comes back and she's got a mass. I'm like, oh shoot. I don't know if it was coincidental, I don't know if she was just presenting the right way, but I'm glad I did it. So, repetitive vomiting. So 1 episode, 2 episodes or more, okay, I'm interested. Severe MOI, what do you mean by that? Yeah, jaws of life, any proline extrication. You look at some of the injuries, like your patients will come in and show you pictures, like show you videos of people, and you're like, oh, like, oh, they got hit in flag football, and you're thinking like, and then you see it, and it was like, Terry Tate, office linebacker, just came, and you're like, oh no, and they like hit their head, and they get up, and you're like, yeah, we probably should scan this. Like, that doesn't look good. So. Any underlying coagulopathy, so if they're on blood thinner medications, if they're old, 65 or older, scan them, and then 30 minutes of retrograde or persistent anterograde, anterograde amnesia, or if they're intoxicated, circle the bottom line, intoxicated, drugs, alcohol. Patient comes in, doc, I was in a car accident, I just got a little bit of a headache, I got a little bump on my head. Scan them or not scan them? Scan them, they're drunk, right? I didn't mention that. So they stink of booze. Scan them. Why? But why? They seem like they're making sense. Blood thinner? It's alcohol? Are you reliant when you're on alcohol? You're like, yeah, I'm the best driver in the world. Don't be that guy or girl, right? But you're like, I make perfect decisions when I drink a fifth of vodka. No, you don't. So they're intoxicated. They're not a good historian. We don't know what happened. So scan them if they're drunk. Scan them if they're on drugs. Does that make sense? All right, post-concussive syndrome. So this is a state following a minor TBI with consisting of a combination of fatigue, dizziness, headache, difficulty in concentration. What else do I want to say here? About 7 to 10 days, so I would know kind of timeline, unfortunately. So usually after a first-time concussion, like 24, 48 hours, you start to feel better, to be honest with you. So this person has post-concussive symptoms, right? And they've got the symptoms that we just mentioned. In that 7 to 10 day window, you can think post-concussion syndrome. It's an ICD-10 code. So again, what do we do as providers? We just kind of keep treating the symptoms, excuse me. Okay? This can turn into post-concussion disorder. So this is greater than 3 months. This is down the road. So right, so for concussion syndrome, we think 7 to 10 days. Just think 10 days, really, like a week or 10 days after the concussion event, and then we get all the way to 30 days, greater than 33 months. They're going to have post-concussion disorder. Okay, does that make sense? So it's kind of a paradigm or spectrum of concussion symptoms that continue. So a moderate TBI, your GCS is now 9 to 12, like we mentioned on that first chart. Treatment, admit them, image them, right? So these folks, again, if you have a moderate TBI, your GCS is like 9, you're going to want to get neuroimaging. It's not like, well, they're a good 9, they feel good, they're making sense, just image them, right? Severe TBI, 3 to 8, intubate if needed, admit, image, manage your ICP. These folks are in pretty bad shape, so probably have a brain injury with bleeding or something else going on. So just keep that in your back pocket. So these folks are definitely sick and they're not going home. So, all right. Cranial nerve injuries to worry about with your TBIs just by location. So remember, 12 sets of nerves innervated from the brainstem to the parts of the face. So we may be seeing some of this with our cranial or with our TBIs, whether it be mild, moderate, or severe. So olfactory nerve, optic, ocular, motor, trochlear, first and second brains, trigeminal, and then your auditory nerve. But that's really basic. If you think about it, what am I talking about here? I said motor vehicle is the most common. What do you think they're doing? They're hitting their face. So they're hitting their face. So. All right, subdural epidural hematomas. So kind of go over an intro here. We'll talk epi, subi, and then life-threatening issues. So epidural hematoma typically presents trauma, progressive coma, lucid intervals. Circle that for me. You're going to get this on your pants or panry or whatever you're taking. This is going to be the most common cause of, or most commonly caused by trauma to the middle meningeal artery. That may be something that you'd want to know as well. suspected with a patient with a temporal skull fracture. Classic CT findings, which kind of like, I'm pretty sure you guys have a question on my exam for this. You get a convex hyperdensity on the side of the brain tissue in the parietal temporal region. Mortality, 100% if we don't treat it. That's bad. Get an urgent CT non-con, and then rapid neurosurge consultation. I know we'll take a break after this. I'm almost there. I got like 16 more slides. So. You guys good to finish? You want to take a break now? Just push? Okay. So lucid intervals, what is that? Not to insult you guys, we already talked about it. Yeah, so that's that rebleeding, right? So that's altered, that state, they get out of the car, they pass out, they get up, they walk, they pass out. So they have these intervals where they're just going up and down and up and down. And you'll see that, I don't know, you'll see it on your pants a lot. So if I give you guys a test question, look for this exact picture, okay? This is an acute epidural hematoma, right? Tightly attached to the dura. I don't know how else to make you guys remember this. Was there anything else from radiology that they talked to you about? Say football? Yeah, I heard that one too. That's your jam. Go with football.
Yeah.
Okay. All right. Contrast to the subdural. This is great because I showed you guys my old man the other day from the ladder. This is what he had. So probably should have done this first, but I didn't. You're welcome. So this is accumulation of blood within the subdural space. This is from veins as opposed to a epidural, which is arterial bleeding. So, you know, I didn't say it, we said it the other day, but arterial bleeding is usually going to be quicker, so we need to be aggressive on both of these, but subdural could be hours to days, so just keep that in mind. I see like chronic subdural hematomas in these old folks that are falling, getting up. Go to scan them and it comes back, it's like chronically appearing multiple subdural hematomas, and I'm like, what do I do, right? And they're like, we're doing nothing. Like, it's been there for a while, we're not going to touch it, so it was interesting to find that out, because I always remember being a student and being like, I better never see one of these. If I do, I better be ready. And then I saw them and they're like, yeah, nothing. I'm like, what? I was lied to. So, all right, you guys can see that on the CT scan. Everybody appreciate that when you guys are looking upper right side, causing a right to left shunt a little bit. Is that okay to say? Dare I say that? So, okay. Lower pressure will clot faster, so stretching of the meninges can cause headache. Irritation of the cerebrum can cause seizures, right? So again, this is, and we've said this a bunch, so you may, if you find it, great, but we're going to treat it with anti-seizure meds, we're going to give them anti-emetics, we don't want them to throw up, plus or minus pain medication. Bottom line is we need to get them to a neurosurgeon so they can do either drilling holes or just taking flaps off their skull. So they need to evacuate the clot. And that's a pretty cool thing to watch if you ever get a chance to do it. But I hope you never have it. I mean, I don't know, I didn't know what to say there, so I just came up with something. But I'm like, I hope you never have one. God bless you guys. But I don't know how this person did. I'm assuming they didn't do well. So I know. This is post-mortem. They did not make it. He's like, it says an autopsy. We're dead. I know. That's a joke. All right, coma, definition time. So coma is a deep sleep-like state with your eyes closed in which the patient cannot be aroused. Definition of stupor, definition of drowsiness. Those are easy 2-pointers. Just take a look at them. I might give you a definition of like, I don't know, coma and ask you, what is the definition? The following definition is blah. So just take a look at it and we'll talk about that in the review. What causes it? Structural damage, right? To the RAS, or abnormalities in the cerebral hemisphere. So damage to the brain, underlying tissue. Suppression by drugs, toxins, metabolic issues, anoxia, uremia, and liver failure, right? So uremia is usually second to liver failure, but again, that's kind of something to consider. Your most important brainstem reflexes, your pupillary signs, ocular movement, and then respiratory patterns, so some things to consider. So pupillary signs, we all feel good with that. Eyes are pupillary around, that's good stuff, right? So ocular and caloric testing, anybody seen this done before? So inner ear, water in the inner ear. Yeah, so I'll bring up a picture or maybe a short video of this, but the doll's head thing is pretty easy. I've actually never done these, but I've seen neurosurgeons do them. So they'll pick up the head and they'll just move it left to right. They're looking for the eyes to stay straight, or they just drop it with the head, right? So you guys can see there, moving left to right from blonde, brunette to gray. So Century looking, eyes left, right, with the head rotated to the right, and then you guys can see the opposite there. So your cold caloric response is pretty neat to see. So I think there's a good video out on the internet. Maybe I'll find it in the next break. But you shoot cold water in your ear and you're watching for nystagmus beats. If you don't have anything, you're probably, your brain is not working. Your oculocephalic reflex is probably kaput. Let me see, is there anything else I want to say about this? I think, there was something I had, but I can't find it. Oh, the acronym COWS. Anybody heard this before? So cold, opposite, warm, same. So this has been used to remind generations of medical, I'm just going to read it. Used to remind generations of medical students of the direction of nystagmus. Cold water, opposite, warm water, the same. But since nystagmus is often absent in the opposite direction due to the frontal lobe dysfunction and coma, the mnemonic doesn't really hold true. So if you hear COWS, like, you don't have to correct everybody, but just know they're talking about oculocephalic testing. But again, if I put cold water in your right ear, where do you think I'm going to see the nystagmus? It's going to go towards the right. So when you look at COWS, cold, opposite, warm, same, it just kind of doesn't make sense. So I just want to make it more complicated for you guys. You'll get into your neurotation, they'll be like, I did a COWS test, and you'll be like, it's dumb, it doesn't make any sense, right? You can say it if you wanted, but I wouldn't say it like that. I'd be like, oh, excuse me, sir, ma'am. I always thought that that's actually an improper mnemonic. They'll be like, oh my God, right? Intellectual discussion. So this is just showing you the pupillary response and what's happening, so the pathophase behind it. Labs. So what do you think you guys are going to do before you either suspect or diagnose somebody in a coma and or dead? How about everything? Like, hey, like, what does that mean? So you are truly gonna check every lab, right? So why is this person, you said metabolic, drugs, we talked about a bunch of reasons, toxins, anoxia, uremia, liver failure. So we're gonna get some labs and check what's going on. So CBC, Chem7, LFT, PT, PTT, ABGs, VBGs, so I wanna check all that stuff. Neuroimaging, CT, right, CTA, LP. So this is like a full course prep. So when you say like, I want to do a like max capacity workup in an ER, ka-chow, like that's what you're looking at. So, and I'm not doing an EEG in the ER, but mostly to that LP, and then be like, hey, I don't know what's wrong with this person. Like, you guys can keep them because that EEG is going to be how long do you think? We're going to wear that head thing for like 24 hours. So unless they catch something early, they'll be like, oh my God, we see 50 to 60 hertz spikes. We got to do something now. So. All right, brain death, please know the definition. Irreversible, 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 loss of function of the brain, including the brainstem. Right, brain death from primary neurological disease usually is caused by severe head trauma or aneurysmal subarachnoid hemorrhage. Irreversible, irreversible, right? Loss of brain function may follow hypoxic ischemic brain insults and fulminant hepatic failure. So this is a reversible or irreversible state. You guys got it. So. Again, in case I'm just being a total jerk up here, it must be demonstrated irreversibly. So, must be demonstrated irreversibly. So again, a couple highlights on here, you guys can read it. So no drugs or toxins or poisons, so you gotta try to metabolize or neutralize. And then core temperature, you guys probably heard this in cars, but they're not dead till they're warm and dead, right? So they can't be frozen, right? They can't have just fallen into a ice cold lake or fell asleep outside and come in and they'll be like, oh, their core temp is X, they're dead, right? They need to be warm and dead. All right. 3 cardinal features of brain death, God bless you. Coma, unresponsiveness, absence of brainstem reflexes, and apnea. We haven't talked about apnea yet, but did I just glance over it? I hate going backwards, it makes you guys more anxious, but that's all right. All right, we're just here. So pitfalls in diagnosing brain death, right? So things that might interfere with your diagnosis. Severe facial trauma looks bad, but you'd be surprised what the body can handle. Does anybody remember seeing the picture of the dude that did the blasting cap, just sitting there, his face is like an octopus? Homeboy was just sitting up, breathing like no big deal. So clearly you wouldn't be like, you're dead, right? Safety kill. You should have got one beforehand, but severe trauma can kind of convolute our physical exam. So pre-existing papillary abnormalities, drug levels, TCAs, other drugs. So again, locked-in syndrome, maybe secondary from a stroke, and Guillain-Barré. So just some things to consider in your differential. Before they're dead and it's irreversible, we need to make sure we check all the traps. Medical documentation, right? So when you guys document it, stakes are high. So can PAs pronounce death? Yeah, in Texas you can outside. In the Army, Chris, we can, right? Yeah, me too. I don't put you on the spot, man. I don't know. That's why I'm asking. You guys can Google search it, but I hadn't. I mean, I think we can. I'm pretty sure we can. Actually, for a fact, I know we can. But outside, it's a little strange to me. So first time being out there, DOs, MDs, APPs, so PAs, NPs, and then 2 nurses. What? Like, why 2? I don't know. I guess I gotta high five each other. Yeah, they're gone. I don't know why it says that, but. All right, just make sure you're documenting. This should just make sense, right? So when you, I hope you guys never have to do this, but if you're working on the outside, it's gonna happen. If you're working on the inside, chances are it's gonna happen. Just make sure in your documentation, you expressly annotate that it's irreversibly, right? You don't have any brainstem reflexes. There's no motor reflexes. Absent respirations with PA, CO2, PCO2 greater than 60, so they're not breathing. And then repeat neuro exams, etc. So just be thorough. And again, kind of sounds silly, but that's one of the CYA things. I don't want to see you guys get in trouble. I actually had a doc while we're getting ready for a break. I had a doc like pronounce someone too early. I think this dude was just on a ton of drugs. And got the ultrasound, looked at his heart. I don't know, maybe he was looking at something else, like his spleen, but this dude was not dead. And they grabbed me because I was like the only other person walking there, like, oh, this guy's scary. They're like, hey, Rogers, come here, take a look at this guy. And I'm like, oh shit. Yeah, he's not dead. And I'm like, all right. He was gonna be toast. Like, he had been down for a long time. But it's probably not good if you document someone that's dead and they're not dead. Depends on how you look at it. You may be something special if you're curing the sick that they're that sick. But for our intents and purposes here, we need to make sure that they're gone. So, all right, take a break. I got to give you guys a break. We're just going to do headaches and we'll be done. Dude, you all right? You making it? Brutal? Is it brutal? Come on. Come on. I'm fine. You're fine. We're all fine. This is great stuff. Riveting. Not the most boring instructor path.
Definitely not the most fun. I would say the ophthalmology class we got.
Oh, yeah. Yeah.
He was fun, but he was boring.
I don't know what's just on. Yeah, so that's what works well for them is if that's it. They're having headaches and dizziness. Well, you know that I'm not.
You're right.
That changes your life. I see. That's indisputable. We say no, right? I would not be guys in discussion.
Hey, I need to see a doctor, I think.
I was curious.
Yeah, I'll. First of all, it depends if they have a DNR, obviously, right? So if they have a DNR, sometimes we'll start working something and then find out in the person didn't know that. Yeah.
Or even that have
That's happened recently. or something, or so it becomes like this badge of it's kind of medical irresponsibility where you're like, if you're working somewhere and you're not getting oxygen for 20 minutes. Usually we get folks back to work first couple of minutes, get some sort of. I've seen folks, that guy that I was talking about, flashback, he was probably working like but he's not gonna. So the family gets excited. They don't understand it. I just create and again, that's an ethical discussion. Is it the right thing to do? I always try my hardest. I'll run at least 2-3 cycles of ACLS. I'll stop. I'll ask the team, like, does anybody have any other ideas? No. Is anybody opposed to keep working? No. It's very open. Usually I grab an ultrasound and try cardiac activity. No, I don't. So don't do that stuff. Like I don't do my GCP. They do that stuff. If I get them back and there's a heartbeat, they'll admit them to the ICU and do the EGs.
Still haven't injected.
Yeah.
Time to figure that out.
I know. That's why I said it's embarrassing to say that right now.
They say that that is a sequela of after you get a stroke.
That was about the dark, by the way.
Yeah, I thought about it. I'm gonna get mitral stenosis. 20 years. Murder. Did you tell them? This was like, this is what I want. Like, oh, yeah.
Kyle Johnson used to be on our program. Those guys over here, I think Kyle. Yes. It's my brother. Very good. Yeah. Not confusing at all. I haven't talked to either one of them, but I'll talk to ours, yeah.
That's why. I didn't. I
Oh, shit. I hope you're alright, man.
All the stress.
I hear you. Boy, we're almost there. So you guys have cards 3 tomorrow? And then you have another cards exam before the semester's over? How?
Last exam. Because EKG is also part of cards.
Okay. Okay. Gosh darn it. I thought we were like done. You guys got a sprint to the finish. Pretty good. Pretty good. As if you love it, we're gonna watch it. I was debating whether or not to watch it, but
Hey, I need to see a doctor, I think. I went down on my skateboard, I wasn't wearing my helmet. My head hurts a little bit.
Okay, a headache, but still breathing. Basic. Take a seat in the waiting room.
Where's your ID person? Didn't get one. Think I can ask for him? He's killing me. I don't think you see a doctor. I'll get you an ID.
Hey, sir, get this guy to a queue now.
As people as well, looks like we have a brain bleed. There's no ID person. There's no way to help this test. My best guess is it's a girl you tell me. Where's this patient's ID person? Has he even been checked in?
I didn't have time. He's gonna be okay, right? Because he said he just had a headache.
You didn't need to get that. Why didn't you triage the interrupter? I found him just lying over there, unattended, invasive.
It's my first day.
He had a head injury. That's an emergent always.
So busy.
He had attitude. He should be on contact protocol in urgent.
He seemed okay. Patient, they just kept coming. I didn't want him to be marked as urgent if he was basic.
It's better to be overly cautious with a head injury. All right, everyone, let's get back to work. Is it because of a mistake? Yeah, she'll always carry that with her. Hey, I need to see a doctor, I think.
what do you think? That doesn't happen, does it?
Shotgun laugh every time.
Yeah, so that's why, is you don't want to miss something, right? It's true, we don't want to miss something. So, what do you guys think? Who's culpable? Who's at fault in that, or is it fault, or is it a systemic fault?
Extreme ownership.
It's not my fault. I didn't do nothing wrong. Nothing? Nobody sees anything? Hospital owner?
Extreme ownership.
Okay. Anybody else? How was the patient not triaged? I guess their triage was Bert, headache, walking, talking, you're good. Is that an appropriate triage? Okay, so he takes exception with the triage. What should triage look like in a hospital? We're talking like delayed, immediate, expectant. We're not doing that right now. It's a different class, but yeah. So there should be a provider eyes on. There should be a set of vitals, right? There should be. Clearly there wasn't. I don't know if they were in a mass cal. I don't know a lot, so there's too much information. I'm not trying to shun the nurse. I think she was set up for failure. So, but you may be that. A lot of the facilities that I've worked for out here now are taking APPs as their first line eyes on. So just be aware. Right? So be aware. Like you may be the first person that a stroke victim sees, or a ambulatory headache with a hematoma on their forehead. It'd be a lot better if I could throw a set of vitals at you guys and look at it and do a neuro exam, right? Even if it's give me a big smile, hold your hands out, right? Repeat after me. That's something. But we had a lot of bypasses. It's like, you guys heard that Swiss cheese model where everything went wrong, just kind of went through. But how did he get to a bed in a hospital? Should you be able to just walk in a hospital and lay in a bed? I've never seen that happen in the hospital I worked at. I don't work at a trauma one, so I've heard university is insane. Like I've heard they just have like, the volume is insane, so I don't know. I'm gonna say no. Confidently from what I've seen, like that's not gonna happen. Like you'll either be sent back to triage, they'll either triage you right there, or you're gonna get security called on your ass real fast. What else, anything? No, anybody like that show? One up here. Everybody watch The Resident? Okay, cool. Yeah, just like the Medi-Strip thing I sent you guys, or whatever that was, I got no kickbacks. I don't even know who produces The Resident. So I just think it's a good show. It's very entertaining. All right, headaches. You guys think you're gonna see headaches and facial pain? Of course. So it doesn't matter where you go. Shoot, try to find a subspecialty that's not gonna see it. Let's play that game instead of saying who's gonna see it. Who's not? You're like, derm? Nope, they're gonna have headaches. Podiatry, foot pain, hurts so bad I have a headache. You want to play? It's like 70 degrees of Kevin Bacon, bro. I'll get you there. Yeah. I hit my toe, ingo toenail, like the pain is so bad, it's stressing me out. My head hurts, right? So, anyways, I'm not trying to play a game with you guys, but I know you got study to do, but you're gonna see this, right? And if you guys, there's an assumption on my part. Tell me if I'm wrong, that you've talked tension headaches, migraine headaches, cluster headaches. Have you had all these? Okay. So your primary headaches are probably spot on and will be reviewed. So this is just our classification, right? So there are two types of headaches, neuro-related, primary or secondary. So primary are your migraines, your tension, your cluster headaches, also known as trigeminal autonomic septicalgia, but I like cluster better because I'm a public school kid. And then there's this other type, which is primary headache associated with sexual activity. Like you can't miss that one, right? Like you're having intercourse and you're getting headaches. It's usually secondary to elevated heart rate or blood pressure, but just something to consider in your, clearly the patient's history would be like, every time I get intercourse, I get a headache. You're like, oh, it's probably a migraine, right? No, maybe it's something different. So just open up your differential. And then your secondary headaches are just something else that causes it, right? You've probably been baptized with all of these as well. I would say you've probably talked temporal arteritis a bunch. Pseudotumor cerebri, maybe not so much. We'll kind of rehash that. Drug rebound kind of makes sense. Meningitis, encephalitis, we'll hit that. And then sinusitis, you guys have probably had already. So it should go pretty smoothly, I think. Watch it be a total derailment. Like, no, we don't like this. We hate this. You guys won't do that. All right, very common. This is the second most. So then again, we'll get there. But if migraines are the second most, what do you think of the first most? Tension headaches. So tension and migraine, when you walk in a room and have it, I'm not telling you guys how to practice your medicine, but when I walk into a room and I have a headache, I'm going to put tension and migraine high on the differential. I'm clearly going to put the other scary stuff on there, and then as I work myself into a normal neuro exam, normal findings, these are going to drop, these are going to come up, right? So I have that working differential before I even look at my patient and talk to my patient. And then as I do OPQRST sample history, physical exam, I'm just shuffling it down, right? Oh, you're afebrile, you don't have any nuchal rigidity, blurry double vision, where do you think meningitis goes? Up or down? Down, right? Oh, it's unilateral, pounding, rapid onset, causing photophobia, phonophobia, where do you think migraine goes? None, right? So two things can be true at once, so I'm not telling you it's all encompassing, I don't want to convolute it and throw a curveball, but can a migraine present like a stroke? Probably, somewhere. But when we learn it, we can't think about those zebras because that's going to screw us up. All right, and then these are recognized. The thing I want you guys to look here is recognized by triggers is important. Why do you think that's important? Because if we can find your trigger, we can treat these medically and pharmacologically. But if we know your trigger is a glass of wine every night, like no kidding, what should you not do? Have a glass of wine, right? But I love it. I want to try something different. I got it. Just work with your patients. I feel like I've had this conversation with you guys before. MSG is a big one, right? So whatever, just avoid it. Or know you're going to get a headache or treat yourself prophylactically. I don't know what to tell you. But I love my Chinese food with MSG. I'm like, okay, roger that. I'll work with you. So, all right, these are some of our triggers. Again, so what can cause a migraine? A lot of things. So what can trigger a migraine? A lot of things. I don't think it's really not important for me to have you guys remember a list as opposed to just keeping that wide differential on what could be, number one, is this a migraine and presenting like a migraine? Number two, what could be this person's trigger? Then you can kind of deep dive a little bit and try to figure out what's going on. So, anything on there that you guys want to talk about? Stormy weather, barometric pressure. I wish I was that dude, man. Like I've got the knees going. I wish I could be like, oh, here it comes. We got storm coming. But I'm not there yet. It's like end state for me. That's when I know I've made it. All right, pathogenesis of migraines, it's complicated. So trigeminal vascular system, serotonin, dopamine, and it's inherited. So there's a genetic component as well. So multifactorial. Trigeminal vascular, just having an open discussion. Why do you think? So why could nerves and so remember, you guys have talked anatomy. Where do nerves hang out with? Arteries and veins, right? So that's your trigeminal vascular system. So if you have inflammation of either one of those, if I have a vasculitis, neuritis, or anything, my veins are inflamed, and that's causing inflammation. What happens to the body? What does your body do with inflammation? It attacks it. Very good. Good. You send chemical mediators. You guys remember all these? Cytokine, substance P, leukotriene, esterase. You guys remember? Ish. Just know that inflammatory stew, that's what public school UMass is going to call it today, goes up to the area. What does that white cell march cause? So they all come up to the area, up to my face here, because I got inflammation in this nerve. They're checking it out. What does that cause? Swelling. What does swelling do? Pressure on the nerves, make it worse, right? So those things can help exacerbate or cause a headache. So. All right, we just talked about a little bit of that. I oversimplified it. So trigeminal vascular input for meningeal vessels. Good. I don't want you guys to memorize this, but just be able to kind of understand that inflammation and immune response could. What is 5-HT? It says it there. I was going to ask you guys. Trick question, right? Serotonin. So why do we think serotonin plays a role in this? Because when we treat them, what do you think we're giving them? Right? So we're going to treat them targeting some of that. It says direct role unclear, but if we're giving them medications, right? If we're giving them emetic medications or anti-nausea medications that work on 5-HT, it's probably deducible to think that has a component or a relation with our migraine headache. Does that make sense? Okay. Dopamine, same thing. Genetics, right? Apples and trees we talked about. This is just showing you nerve, artery, vein. They run together, so irritation, right? Don't memorize this just for your learning or your visual learners. I would kind of know this, right? So this is important for when you guys get out and start practicing. So you may get a question or two on this for your exam, but you have to have a diagnostic criteria. Like I can't just see a patient in sick call and be like, this is presenting like it's pulsatile, rapid onset. It may be a migraine headache, and you may be right, but there's a classification system that we have to meet in order to accurately diagnose this, okay? So you can see there on the left, with aura, that's the majority of your, or excuse me, without aura, it's the majority of your migrainers, so 80%. So at least 5 fulfilling B through D. I'm not going to read them out loud, but they got to have 5 attacks fulfilling your criteria in B, C, and D. And then E, it's not attributed to another disorder. And then your migraines with aura, that 20%er, you guys can see the criteria there. So I may give you a patient that has X, Y, and Z, and I just want you to be able to say, is this a migraine without, a migraine with, does it meet the criteria? So, stay tuned, we'll review. There it is, in case you don't believe me. Pounding mnemonic works for me. I said, I think the lowest of the hanging fruit, me. I think this works great, it just stuck with me. So pounding, it's pulsatile, rapid onset, unilateral distribution, nausea, vomiting, and it's disabling. And I kind of added photophobia, phonophobia are also like, if they're, you know, when your migraineurs come in, when you open the door, or curtain, when you go in there to see the patient, turn the lights on, like vampires, bro. Like, you turn the lights off, right? That's usually like a pertinent positive, leaning towards, there's some sort of involvement, obviously with the ocular system, but it could be migraine again on my differential, may come a little bit higher, but okay. Chronic migraines, definition, know the definition. So if there are 15 headache days a month, with at least 8 of them having symptoms of migraine features for more than 3 months. Why is this important, you think? Prophylaxis treatment, and also the way we treat or diagnose chronic migraines. I hate teaching you guys this way because it sucks, but some of like your insurance coverages will allow you to be, will rule you in or out or be, what's the word I'm looking for, eligible for certain treatments if you're meeting chronic migraine distribution. So again, it's important to categorize it, one, because we can say someone said prophylaxis here, which is a better answer than I gave you. But if you sent someone with 3 migraine headaches, and you're like, you know what, I heard Botox is good, or I heard hematology is good, I'm gonna send you or try to get this, you're just gonna get it denied. So they're gonna be like, nope, doesn't meet criteria. So I want you guys to know there's a classification for chronic migraines. A lot of talk over just knowing chronic migraines. All right, their exam, normal. So you do a neuro exam. So are we gonna do a neuro exam on a headache? When are we not gonna do a neuro exam on a headache? Never, right? So they come in and they have a headache, you walk in, and I told you, you're like, oh, but Roger said when you turn the lights on and they act like a vampire, it's a migraine. Bullshit. Baloney. You gotta do a neuro exam. Wow, you got aggressive. I'm down, big guy. So always do a neuro exam, but it's gonna be non-focal. It should look, the neuro exam they shouldn't have any droop in your face. They shouldn't have any visual changes. The pupil should be fine. They should be able to do pronator drift, Romberg. They should be able to do dysdiadochokinesia, finger to nose. I'm not gonna go through the whole thing, but patients are often very ill, but there is so underlying no focal neurological signs. Imaging, not necessarily the typical migraine symptoms. So we can get into a debate, image them or not image them, you don't have to. Recurrent migraines, refractory to treatment, think you guys wanna open up your aperture and look for imaging? Maybe. It's up to you. If they keep coming back and they're not focal and you're like, I don't know, it's a migraine. I say doing the same thing, expecting different results, the definition of insanity. But typically after, seeing somebody 2 or 3 times, I may consider neuroimaging to make sure there's nothing crazy going on. Crazy being like a mass or something like that. So if it's a bleed and we're seeing them like months later and we get it, I'll just hang my head in shame and be like, oh shoot. Hey, what are you doing? I'm fishing on a boat. Oh, your head's bleeding, you should probably come back in. It's not good, it's bad medicine. All right, how do we treat them? So there's the migraine, God bless you. So don't memorize this. This is one of the ones you can bring in with you. So if you're, God bless you, if you think it's a migraine, have them fill this out and document it in their records. So the migraine disability assessment score, your MIGAS questionnaire. I'm not gonna have you guys partner up and do it to each other. It would be pretty silly because does anybody have a migraine in here right now? You're like, we all do, listen to me. You're holding your head like you're mine, man. You're like, oh God. But you could do this, document it. Next time they come in, do it again, see where it's going, and then trend it out. So just something you have in your tool bags. How do we treat them? So who gets non-farm management? What does that mean? Lifestyle mods, get better sleep, stop drinking the alcohol that's causing your triggers, right? Sleep hygiene, all that stuff. De-stress, drink water, exercise. Great stuff, right? So everybody should be getting that, probably regardless, but these are specific for these migraine folks. For an acute TAC, so analgesics and NSAIDs, so your serotonin receptors or dopamine receptors will work well, and then prophylaxis therapy we'll talk about in a second. So it's kind of straightforward, but everybody gets it, we talked about it, we'll go past that. Really for your acute attacks, if I give you guys a question or you're out there treating somebody, like an acute attack and they're PO tolerant, remember nausea vomiting comes to this. Like a gram of Tylenol and 800 of Motrin, not a bad swing. Not a bad swing at all. Can I give them together? Yes. Well, number one, they're young and healthy mostly, but different pathways, right? So one is renal, one's hepatic. So everybody like freaks about that. And then peds, they'll tell you to piggyback it, right? So do one, do the other, do one, do the other. Yeah, they're just born, they're little. You guys aren't peds. But I give someone a gram of Tylenol. I give them 800 Motrin food. Please give them like a cracker so they don't start vomiting on you. It's like, oh, you were nauseous, but now I give you 800 Motrin that's causing that gastritis. And they're like, ugh, right? You're like, oh, I don't know what's going on. Are they getting worse? Are they having NEURO signs? Nope. You just probably irritated or something. So. Yeah. Can you choose other NSAIDs? Sure. Do you have to give them Tylenol? Nope. But I think it's pretty low. Another one that's in there is excedrin migraine. I didn't have that a couple times, and this is not, you guys won't see this in farm, like, I think I told you about Mountain Dew, but I've given some, I don't know why this keeps coming up, but I probably have to do an internal reflection myself and how I practice medicine, but a gram of Tylenol, 800 Motrin, and a Mountain Dew is like, I'm ready. Bring it on. And you're like, well, this Mountain Dew stuff's really good. Now they're hooked, they have diabetes, but you come cure the migraine. So, like, I never had Mountain Dew. What is it? They drink it and they're like, woo! I'm going streaking at the quad. Like, I'm doing that. All right, so non-select, so your ergotamines. I've never used these. They're out there in the literature. So ergotamines, dihydroergotamines, those are like fungus. You guys learn about these? Yeah. They're there for you if you want them. Go for it. It's in the literature. Chris, you ever use any of these? They're falling out? Yeah. They're there. I'm not going to quiz you on them. Just know some older folks might use them. Triptans all the time. So these are super easy to remember. They end in triptan, right? So I thank God whoever came up with this nomenclature. But sumatriptan, I don't care if you memorize the name or the specific one. Sumatriptan is pretty popular. Rizatriptan. So those ones are again, they work well. So, all right, your ergotamines, just a little more information, right? You give them with caffeine again. Caffeine, why do you think that's going to help? Helps absorption. What does it do to vessels? Constricts, the vasodilator. So again, it can help with constriction. And again, if you have inflammation around the vessel of your head, if that's part of it, constriction, that might help a little bit as well too. All right, your dihydroergotamines, hard pass, but they're out there. I'm not going to quiz you on this. Triptans, what they are, right? So again, different, you can administer these. I don't know if I get into it too much here. So these work really well for abortive therapy. So if your patient like has migraines and they know they're going to have a migraine, if they have it more and they feel it coming on, usually that's when I'll hit them with a triptan and be like, hey, take this. Like, if you can predict when you're going to have a headache, you can try it to break it, but for abortive therapy, they work real well. See at the bottom there, sumatriptan with naproxen, so there's combination medications. TRICARE wouldn't cover that for the longest time, so then you can just order them independently and have them do it together. I know, it's a pain in the ass, but say la vie. They're like, apparently, and I can't lie to you guys, but separately, they're like, I don't know, let's just arbitrarily say $1 a pill. For some reason, you put them together, they become like $50 a pill, and they're like, we're not going to pay for that. So you can just still, if you want to do that, just order them separately, have them taken together. Voila, you now made surpass that. You guys, unfortunately, will see that a lot. Some of the TRICARE stuff that you do, it's frustrating. Just find a way to circumvent and keep working hard. All right, what's the meaning of this? Wow, there's a lot of information. So these are some doses, right? So don't memorize doses. There's also different ways you can administer triptans, which we'll get into here in a second. So if they're having trouble and they're nausea and vomiting and they can't take it, give it to them nasally. They can do an injection parenterally. You just have to kind of think, okay, do I want to try a triptan? Yeah. First of all, is this a migraine? Does it meet migraine classification? Yes. Are they PO tolerant? No. What else can I use? Let's go into my arsenal and see what I have. Try a nasal administration. You can give an injection. You just got to figure out how sick the patient is, what they can tolerate, and what you have in your formulary. So, does that make sense? Am I talking too fast for you guys? I feel like I'm now becoming the micro machine guy. Is that okay for everybody? Just keep pressing forward. We have cards to study for. Okay. All right. So dopamine receptor agonists can be adjunctive therapy. That's going to increase gastric motility and improve absorption of medications. It also helps relieve nausea. Again, you've got oral and IV forms of that as well. Some examples: Reglan, Compazine, right? So it's definitionally, like, this is what you need to use, but what I like to use, if there's no contraindications, i.e. they're not pregnant or have a bleeding disorder, I'll do Toradol, Reglan, and Benadryl for my headache cocktail. Some people don't want to do that. They'd rather do Copazine, whatever you want. I'm not going to ask you which is the right headache cocktail medication. But if I have somebody come into the ER and I see them and it's a migraine and I'm trying to break it, I'll probably start a line. They can't tolerate PO. I'll give them a bag of fluid, probably 15, 30 of Toradol, 25 or 10, 10 of Reglan, and then usually 25 or 50 of Benadryl. What do you think Benadryl's going to do? Put them to sleep. What, you feel better when you wake up? Yeah, they usually go to sleep. Like if they don't or something's different, you gotta kind of expand your differential. Like I told you, the young lady I had who I gave that to her and she's now intractably vomiting. Something's not right. That's not what that medication should do. My first thought was she had no allergy and I'm like now creating anaphylaxis, secondary system involvement. She didn't. She had a tumor in her head. Pick what you like. You guys gotta, again, that's the art of medicine. Just practice, work with it, see what works for you, what doesn't work, and then kind of adjust. But again, from my experience, I love my headache cocktail. My go-to is Toradol, Reglan, and Benadryl. That's enough for that. All right, preventative treatments. Who gets it? Patients with increased frequency, so if they have that chronic migraine definition, 4 or more attacks a month. This can take 2 to 12 months to be efficacious. 50% will see success with one drug, one stable, continue for 6 months, and then taper off. So what can we use? Beta blockers, antidepressants, anticonvulsants. It's a lot of meds to memorize, so again, we'll review this, but beta blockers, what's the big not contraindication, but side effect for those ones? Bradycardia, so what does that make your patient feel like? You guys heard of beta blocker blues? They talked to you about that? So yeah, you just feel like you're like in slow motion. Anybody ever been on one of these beta blockers? So I had the luxury and iPad. Told you guys this, it's telling me to shut up, but I developed PVCs. I guess I was just super stressed out. I was like an introvert, believe it or not. I'm just like, why is my heart doing this? Probably wasn't the caffeine and the energy drinks, the dip. None of that had anything to do with it. So I went to the doc. I went to see my PCM. This is gonna delay you guys. Just let you know. It's a good story. My PCM. I went and saw my PCM, and they did some screening stuff, and they're like, yeah, we think you're stressed out. We also think you have ADHD, and I'm like, oh, neat. Right? So they put me on Adderall, so how did that make my PVCs work? So they gave me a low-dose Adderall, so now I'm walking around, I walk up a flight of stairs, and I feel like I'm gonna die. So I go back to the wizard, everybody know the wizard, psychiatrist, right? I call him the wizard. So he's sitting there, this dude was rowdy, man. I'd sit on his chair, and he wouldn't open his eyes or look at me, and he'd be like, oh. So you think Adderall is making your heart race? And I'm like, yes sir, 100%, I feel like I'm gonna die. And he's like, let's double your dose. I don't think you heard what I said at all. And he's like, look, double your dose. So I'm like, I don't think I'm going to do that. So I just stopped taking it. I dealt with who I was, whatever. 100 N, let's see, I fast forward. I stuck with it for like 6 months. Got out of phase 1, survived. Got to phase 2, and I actually thought I was either having a panic attack or heart attack. So I go to the ER. I think it was my rotation. They're like, what are you doing here? I'm like, nothing. Just give me an EKG to see if I'm alive. They check me in, they do all these tests. They're like, your thyroid's out of whack. I'm like, no, it's not. Lab error. But they sent me to CARS. Where the hell was I going with this story? Oh, CARS put me on a beta blocker, and all the beta blocker did for me was make me like a zombie, man. Did it help my PVCs? Yeah, it calmed it down. When I ended up doing my Holter test, like 27% of my heartbeat, the 24-hour period were ectopic, so I had what he told me, you have an excited area of cardiocytes. This is CARS, this is for you guys, right? They're like, you have an excited area of cardiocytes that are just, they're not playing to the rhythm of the, I'm like, all right, cool, what are we gonna do? He's like, we can insert a catheter through your groin and just burn them. That'll shut them up. Or we can try this beta blocker. I'm like, and the beta blocker, I'll try that thing first. So I tried the beta blocker, it made me feel like crap for a couple months, and then I was like, you know what? That's just like, you guys are all gonna be the worst patients ever. But finally, after all this great medicine, however $1,000 workup, I'm like, you know what I'm gonna do? I'm gonna stop drinking caffeine for a while. I'm gonna de-stress my life, damn it. So like, stress went down, caffeine went down, and I was like, one day I woke up and it was like, hey, it's gone. Hey, it's gone. And every once in a while, from like 6 cups of coffee deep, even here, like my stress is like 0. But even here, like if I drink too much caffeine or I go down and have like my third Alani for the day, I'm like, gosh, yeah, there it is. You're still there. Oh, welcome, right? It just goes away. So, anyways, long story. Beta blockers make you like a beta blocker blues for a reason. That's where I was going with that. It just made me feel like, honestly, it made me feel like I was depressed. Like I feel like you could have came in here and I could have been the lady that they threw the football at, and I would just let it hit my face and be like. Like, what's wrong with you? And I was like, man, you learn about stuff and you read about it and you tell your patient, like, hey, this could cause some lethargy and you may feel run down, and then you have it and you're like, holy cow. I downplayed that, but all right. Anyways, long talk about that. All right, tension headaches, by far the most common, primary headache type, right? Lacks a uniform criteria. Episodic attacks, 78, that's probably slow, that's probably low. So I'd say most of us here has had a tension headache in their life. So pathophys unknown. Presentation, you get a bilateral band-like distribution. So this is a little bit different, right? So when I go in and say unilateral from a migrainers, and I'm like, hey, show me where your headache is. And they're like, oh, it's right here, it's behind my eye. And I'm like, is it on the other side? No, it's right here. You're supposed to come in and be like, it's all around. It's all around my head. And it feels like my head is being squished, right? Squished in a vice or something like that. So that's your tension distributions. Physical exam should be fine, right? Your neuro exam should be normal. They get a vice-like distribution. They do appear uncomfortable, so again, not totally unlike your migrainers, but I think your migrainers definitely get the trophy for first prize on presentation. Normal in between attacks, and then no studies necessary needed if you strongly suggest a tension type headache. Okay, unfortunately, yep, there's a criteria. We'll review it. I'll keep you guys out of the weeds, but I want you to know that there's episodic and chronic tension and what meets the criteria, okay? I'm not gonna read this to you guys. I always say that I'm not, but just take a look at the middle part. So 2 of the following characteristics, and then read, there's 1, 2, 3, 4 of them, right? So just read those. And then again, what would make it chronic? So 15 headache days per month for 3 months. And that's very similar to your migraine headaches, so that should be smart to memorize. Whose criteria is this? I'd be remiss if I didn't memorize. So this is not mine. This is the International Headache Society's diagnostic criteria. So this is very commonly used for your headaches, okay? So this is the vernacular that the international medical field uses. All right, this is a useful clinical approach, right? Headache, no nausea, no vomiting, no photophobia, no phonophobia, no aversion to odor, no throbbing, no aggravation with mood. So again, keep it in your differential and start working through your subjective and objective. And once you see what they're saying, you can kind of work either migraine, tension, which one is it? But I'm going to tell you and share you the mystery, right? So we kind of treat them eerily similar, but you'll see here, so non-farm, who gets it? Everybody, relaxation, massage. I'm not massaging my patients, they come in. Just be careful, like I think you have a migraine, lay face down, you start rubbing someone down, get yourself a little bit of heat there, so. But if it's tension related and they got a lot of tension in their occipital region, right, their neck area, their shoulders, you don't realize this, but a lot of people carry a lot of stress and they walk around like this all day, shoulders shrugged, neck forward, looking at their iPads, right? Yeah, you can tell them, go get a massage. Will TRICARE cover that? No, it's misleading. So sometimes, if you're lucky, sometimes PT will do some like deep needling or massage techniques, but if you send somebody strictly there, they're not gonna take it. Yeah, hell no, you gotta go pay for that. All right, the good part is simple analgesics. So I told you guys to grab a Tylenol and 800 Motrin should work for a migraine, should work for a tension headache too. So it's not a bad first line intervention. Prophylactic drug of choice for your chronic is amitriptyline. So that's the only proven treatment. So circle that one in the bottom for me. I want you guys to know that. Don't follow. Cluster headaches, right? So we're still in our primary type headaches. Cluster headaches, primary headache. This is less common, but you'll know it when you see it. So severe stabbing, boring, excruciating, right? Knife pick in the back of the eye, side of the head, that type of thing. So you can see the duration there, 15 to 180 minutes. That's really not helpful for me because you know, when did it start? You're gonna ask them all that stuff. What else do I want to say there? Circle, my cursor's not working. Or, whatever. Circle this right here. So this association with ipsilateral symptoms. I say circle this. I had a pain a couple years ago, and that was the tip for me that it was a cluster headache. You can read the question, and it's like they have a unilateral lancinating stabbing pain that just started, and you're like, it's a cluster headache. But then they went further on to tell me your physical exam. You had conjunctival injection, lacrimation, oral fullness, rhinorrhea. What's rhinorrhea? drainage from the nose. Like, you know, you ask your patient too. You have clear rhinorrhea is what you're going to see here, but it could be purulent. Not in this case. That would make me think infectious etiology. Cluster headaches definition, International Society, right? So again, just understanding those symptoms down there in C we just talked about. So if they have that ejection, lacrimation, nasal congestion, eyelid edema, forehead facial swelling, and then meiosis or ptosis, just think about cluster headache, okay? 100% O2, this is a neat one. So how many people in here think they'd feel good if I just put you on 100% O2 for 10 to 12 liters a minute for 15 to 20 minutes? How many people say yes? How many people say no? How many people say I don't care? All right, half of you don't care. Yeah, so again, probably would feel pretty good, right? If there's no contraindications and you don't have a problem breathing oxygen. But usually where I was going with this, think about someone that's like, I work with a lot of rowdy people on the outside. These aren't active duty military folks. They don't judge each other, don't judge me. They come in, they're hungover, first thing they do, then they go into the back room, start an IV, and give themselves some O2. They feel like a new person. Don't be that guy or girl. That's not good. Like you don't want like the CFO sitting in the back room, like get an IV and suck an O2. Like what's wrong with you? Like I had a good night, right? But generally speaking, that sharp stabbing pain behind their eye on that one side is going to get better with O2 administration. And we need to know that. So we didn't talk about administering O2 for our tension or migraine headaches, but for cluster, we're going to do that. So sumatriptan nasally, oral is not going to be effective, so your nasal triptans could help you out. And then preventative therapy, verapamil is going to be your first line. Does anybody know what verapamil is? CCB? Yeah, good. All right, then your primary headaches associated with sexual activity. I feel like I already talked about this one. So severe sudden headache at the end of an orgasm. So if your patient's coming in post intercourse headaches, what are some other things you want to think about? Don't immediately jump to this. So if you're having intercourse, you get a severe headache at the end. Stroke, right? Like let's make sure we're ruling out stroke, right? Might not be a bad way to go, but let's make sure we're thinking about that. So if they're doing, let's see if I want to say this out loud. Yeah, why not? If they're doing it right, their heart rate should be elevated, right? Right, that's fair. We're all adults here, right? I can't imagine like a scenario where that's not happening, but I'm sure we could go down a different route. So we're worrying about a vascular event first, but we clear that deck, it's not that. Start seeing a repetitive pattern. This could be a primary headache associated with sexual activity, okay? So you see at the bottom there, rule out subarachnoid, absolutely. This is thought to be related to increased systemic blood pressure, okay? Gotcha, all that stuff. All right, secondary headaches, and we're done. Let's just go through temporal arteritis. Have we talked about this previously? Okay, also known as giant cell arteritis. I think this picture makes it into all the medical, or at least the IPAP discussions about this. So just because this dude has a prominent vasculature there doesn't mean you can't walk around Walmart and be like, it's giant cell. Oh my God, temporal arteritis. So but this guy came in and he had a headache there and he went to touch that and it's very tender. That's moving up on my differential, okay? It's caused by inflammation of the external carotid artery, it's superficial temporal artery, it's more common in your elderly folks. And then it says women greater than men. I found this more in men, but that's what the literature says, so we'll stick to that. Pain over the scalp, temporal artery, you get a headache, jaw pain, right? Or stiffness when chewing, so how do I figure that out? When you're doing your physical exam, open your mouth side to side, that hurts, right? Pertinent positive, right? Pertinent positive, this could be giant cell arteritis. So you could get inflammation of the ophthalmic artery, so they could have ocular symptoms, so just keep that in mind. If they're coming in with monoocular visual complaints, keep this in your differential. Fever and weight loss as well, right? How are we going to diagnose this? So we're going to have a high clinical index of suspicion. I don't put a lot of ESRs or CRPs in the ER. If I do, I'm suspicious of something like this. I either want to rule it in or out. But if it's high, what does that really tell you? That there's an inflammatory response? Sure, right? So again, you can tether that to your diagnosis. Old dude, old lady comes in, she's tender here, she's got some right-sided visual complaints. My ESR is 80. Be like, yeah, this walks like a duck and quacks like a duck. I'd say we treat it and then make sure we trend that though. So that in itself is not very sensitive for anything, or specific, excuse me. It's sensitive for inflammation. All right, treatment's gonna be prednisone, burst, and taper. And then you can see the bottom, really the best way you can see, I should have started with this bullet, is to truly diagnose it, they need a biopsy of that. Who wants to do that bedside? Yeah, if you're thinking about biopsying an artery bedside, I can't say I failed you, we have failed you collectively. If you're scrubbing in for it or something, outstanding, or they're doing it bedside in ENT, it's awesome. You can ask to be part of it, sew it up, whatever, but don't be doing that to your patients. I'm gonna punch your artery and see what happens. We're just gonna do a punch biopsy, just a piece. You just made your morning very exciting. Let's go for a ride. All right, idiopathic intracranial hypertension, also known as pseudotumor cerebri. This is a tough one to make. So headache, papilledema, pulsatile tinnitus or tinnitus, and then visual loss or diplopia. I put the picture there because it hits a certain demographic. Not trying to pick on this lady, she's probably got a beautiful voice. Young, so younger, middle-aged females, overweight. I don't know if she had menstrual irregularities, that's not fair to say. But usually with PCOS or other menstrual irregularities, metromenoragia, irregular menses, that type of thing. So you can also see it with certain drugs, right? So you can see it with corticosteroid withdrawal, just to keep that in your differential. Characterized by recumbent headache. What does that mean? What the hell was that? What was that? So what's a recumbent bite? Someone fart? Was that gas? Got it? Oh, nice. Yeah, all right. Whatever, I just told her, was that on purpose? You shouldn't do that in class, it's very disrespectful. You've lost all military bearing. Get your ass out of here. That was good, man. I thought someone sneezed or blew their nose. All right, so sitting back makes it worse, sitting up makes it better. Let's just move forward. What else? You can get tinnitus, ringing in the ear. Physical exam, you can see papilledema. You can get a bilateral stitch nerve palsy. And then they can also have diplopia or diminished visual acuity. So something to consider. Again, I usually see these folks like after they've been diagnosed, they come with shunt problems or something like that. We'll talk about that in a second. So pathophys, possibly impaired to resorption of CSF. Damaged arachnoid, granulations, clot formation of dual sinus. This is neat stuff. But regardless of the cause, they get elevated CSF in the absence of intracranial pathology. So, imaging, you get that venous sinus imaging to rule out thrombus formation, so rule out any clots. And then MRI or CT is going to show the slit-like ventricles or dilation or opening of the optic nerve sheath, which you can also do at bedside ultrasound. See that too. Treatment, so this is neat, right? So when you do a tap on these folks, so if they have too much CSF and you do an LP and you tap them, how do you think they feel? Better. So they may come in, like these folks come in all the time and they're like, I'm just here for a therapeutic LP. I'll entertain it. I'll play a silly game. Like I think it's fun. They shouldn't be doing that in the ER, but regardless, it'll make it feel better. So again, that would be perfect positive. Like I don't know what's going on. I'm trying to rule out some scary stuff, meningitis, encephalitis. Do a tap and they're like, oh man, I feel a lot better. You're like, huh, interesting. Like most people don't feel better when you stick a needle in their back and drain fluid. That's different for these folks. All right, and then they'll be treated with this lumboperitoneal shunting. What is that? It's a shunt or a straw, small straw, right, from up here down into their stomach. So I know who's putting that in, not us at the fly, but sometimes you'll get these folks that come in, if they have a history of this, I now image this to make sure it's not, it's patent, make sure it's not kinked or displaced or something like that. So, and then I usually will treat them and then call their neurosurgeon and be like, hey man, they're like, whatever, you send them to the outpatient, I don't care. All right, neoplasms can cause headaches, right? So headaches most common at time of diagnosis of a tumor, right? So 30% have a headache as their first symptoms. You can read there. Headache is worse in the morning, wakes them from sleep, pain that wakes you from sleep. What do we think? Red flag. Cancer, right? So the patient says, I've got pain that wakes me up in the middle of the night, just think cancer. What are some other cancer signs you guys talked about previously in your ROS? So unintentional weight loss, like I'm shedding weight, I lost 40 pounds in the last 2 weeks. Oh, are you on Jenny Craig? Nope, I'm just losing weight. You're like, interesting. Why does that happen? Do we know why? Yeah, cancer, that hyperproliferation of bad cells that's growing a tumor and maybe metastasize, but they like kind of, it shouldn't be there, so it's abnormal, but they're kind of like hogs if you think about it for some of that nutrition. So again, just something to consider. You guys will talk hemonc, I'm just spitballing here. So could get worse with exertion or valsalva, so hold your nose, blow, that hurts a lot, right? No good. And then they could get intractable nausea and vomiting. So all that should raise your suspicion for a tumor, right? Headache, your non-focal headache, dementia, personality changes. We talked about some of those, right? Your Hutchinson disease, Parkinson's disease, those type of things. But again, how do you think are we gonna neuro image this person if they come in with these symptoms? We're getting CT non-con who says yes. Who's not playing? Y'all should say yes. Come on, guys.
Yes.
All right. Other suspicious criteria to consider, pause for effect. What are we going to do for these folks? Any abnormal neuro finding, right? Worsening headache, headache's not getting better, should all raise our suspicion. Does that look good? You guys appreciate the tumor, not to get up and move, or get over and move stuff? Positive arrow sign on the left one, right sign, you should see all that, that bright white area that shouldn't be there. Is that caught as a midline shift? Yeah, I think so. So it might be minute, but it's definitely looks shifted from here. If you're like, I want more imaging, I'm not mad at you, I want to scroll through that, I want to. Avoid an LP, someone tell me why. So I have this big mass, I didn't do any imaging, I'm like excited to stick a needle in their back. Why don't I want to do that? Pressure changes, right? So again, not cartoon world where I do it and their whole CNS craps out on my boots, but if any minor change of pressure intracranially is not good. So if that's shifting left or right, it's already looking for relief, and I make a hole, that's a vacuum effect. So ungood, don't do that. Always, always, always neuro image before an LP. Never a reason you should. All right, all that to say headache, so what we're talking about. So signs and symptoms of brain tumors, headache, memory loss, cognitive changes. I kind of fall asleep after the first couple. Risk factor, right? Genetics. So always ask a good family history. Exposure to radiation. If your patient's like, yeah, I'm visiting. Where do you live? Chernobyl. Like, oh, neat. How is that this time of year? You're like, oh, I've got 3-headed deers in my yard. You're like, deer, not deers. I hate when you say that. I got a 3-headed deer that's now my new friend. You're like, interesting. I live under power lines. Just, you gotta ask some of those questions. Like, I glow at night, like that kind of thing. Different types, please do not memorize this. When you get to your phase 2 and you delve deeper into neuro, just know that there are different types. This always blows my mind, because I'll find a tumor on a CT, get excited, and call them neuro, and they're on the phone, and they're like, you see how it's encroaching upon? I'm like, nope, it just looks like a circle to me, man. And I'm like, I teach this stuff too, and he's like, shame on you. And I'm like, yes, shame. But he's like, clearly that's an oligodendrocytoma. And I'm like, oh, is it? Like, he's like, well, I won't know until I biopsy it. And I'm like, neat. Good for you. They're out there. Drug rebound headaches. We're getting closer, guys. Bear with me. Probably another 15 minutes if I do this right. So you are going to see this. So due to overuse of analgesics and or caffeine, probably experienced by part of the class here. I know I get this. Keep taking caffeine to relieve the headache. Keep taking caffeine to relieve the headache. What happens if you're addicted to caffeine and you don't take it in the morning and you wake up and it's noon, you haven't had your cup of coffee, what happens? You have a headache. First sip of caffeine, what happens to the headache? It's gone, right? So it's daily headache, could overlie migraines or other headache type symptoms, which you see there. Typically it's related to caffeine and or overuse of analgesics. So treatment, we got to get them off that and try to break it. It's tough. So a slow, gradual withdrawal. And you may be able to use sumatriptan or dihydroergotamine during that transition. But really, I've had great success with this, with just saying like, hey, let's figure out what you're doing. Like, 6 cups of coffee and 6 energy drinks. Like, is it a good idea to tell that person to stop doing that tomorrow? No, they're gonna have a really bad rebound headache, right? So slowly, gradually withdraw from them, just like any other medication. And then I'm a realist. I don't tell them like, don't do that, right? Because I do it. It'd be like hypocritical. Like maybe 1, maybe 2, but 12 is probably, you're gonna have headaches, like it's up to you, what do you want to do? So All right, these ones are important. We talked about them, we've danced around them. So meningitis, inflammation of the leptomeninges, and then encephalitis is the brain tissue itself, right? So you definitely want to pay attention to this. This is meningitis specifically, infection. It could be viral, bacterial, fungal, or other. What do you think other? What else could cause that? Parasitic? And parasites causes? Sure. You guys talked about like tinea, pork, cysticercosis in the brain, right? What's another one? What is it? Just spit it out, bro. Like, yeah, Negliria fowleri. Yeah, that's a good one. It's like people that jump into like warm water, right? Gets through their cribriform palate up their nose, eats their brain. Not good for them. Anyways, keep it in your differential for headache. Maybe you don't want to walk around and be like, oh, it's a migraine, but you could have Negliria, right? But the problem is with that diagnosis, like you would need to be pretty tight with your history. Like, were you recently swimming in like, you know, stagnant water in a pond? They're like, well, in fact, I was. Interesting. But, all right. Headache is a prominent feature, right, due to inflammation. You get throbbing, bilateral, occipital nuchal pains. That's why you do that nuchal rigidity, photophobia, and then mental status changes. Start to happen a little bit late. So, what kind? Try to figure it out. Is it viral, bacterial, strep pneumo, meningitis? How do we manage it? Aggressive antibiotics. But wait, if it's viral, antibiotics don't work. Guess who's not waiting around to figure out that? So, yeah, my goal in the ER is do not delay antibiotics. I think it's meningitis. If they're septic and they're coming in, I have an unknown source. That's what we talked about a little bit. I'm not the guy that teaches farm, but we talked about Rocephin, unknown source, 2 grams. Why? Because it crosses the blood-brain barrier, right? So that's a good one. How do we diagnose it? CSF. So LP, send it to the lab. What is it going to look like? We talked about in a second. What happens? You get or how does it get there? Bacteremia, viremia, fungemia, parasitemia, right? So it gets in the blood, hitches a ride up to the brain. Or you could get direct contiguous spread, like you have a really bad sinusitis infection unchecked, or otitis, it's its way up there. That would be pretty impressive that person can withstand that pain, but you'll see some crazy stuff up there. Focus history, right? How fast do the symptoms progress? Been exposed to others, right? Some common worry about meningitis, usually like basic training techniques. People come across all over the country to a confined space, right? When you guys get out there, you think Prep Med, when you do NTC, CRTC, deployments, it's such a little thing, but sleep head to toe, so we're not breathing on each other, such a little thing. You're like, I don't want to be next to this dude's smelly ass feet. You also don't want to get meningitis or get whatever crud they have. So, have you had meningitis before? Usually that's a recurring thing. So they come in and they're like, I've had meningitis and it feels the same. I'm like, don't worry, it's probably not that this time. No. I'm like, oh God, like, hurt positive is working out there. So neck hurt, neck to chin. I do have all my headaches. Put your neck down, do what I do. Does that hurt? So if they do this and it hurts, right? Is that concerning? Yeah, but typically with the meningitis that I've seen, they're doing this. Not moving, right? Or they look lethargic, first of all. I don't want to misconstrue this. Like, they're sick. Okay? Unless you catch it real early. The time I see them, their headache is getting worse. Maybe they've been treated plus or minus once or twice. Try Motrin, try Tylenol at home. They're usually septic when they come see me. But I'll be like, hey, put your chin to your chest. And they're not doing this. And they're like, yeah, that hurts. So like, no, I can't move. They're like, it really sucks. All right, any new rash, immunodeficiency, ask about HIV, other immunodeficiency disorders. So circle the bottom part, classic triad, headache, fever, nuchal rigidity. Okay, Kernig's and Brzezinski's. I would like you to know these. Kernig's, patient does not allow the knee extension when the hip is flexed. Brzezinski's, patient passively flexes the chin onto chest. So what are they doing? They're relieving the pressure. Right? So if they have inflammation of those leptomeninges and you're trying to stretch that, they're not going to let you do it. They're not going to let you do it. So, bacterial meningitis, right? It's the most common form of CNS infection. Usually strep pneumo, you can see they're leading the way, followed by Neisseria. I'm not sure it's going to be helpful to memorize. Strep pneumo seems to be like the culprit of a lot of things when you think about it. But anyways, you see Neisseria meningitis kind of has a recurrent pattern every 8 to 12 years, mildly deep. I think so. CSF findings. So what's happening here? So we get a polymorphonuclear leukocytosis. So white cells are up, glucose is down. Where's that glucose going? Bacteria is eating it all up, right? So protein's going to be up or down? Up, right? So we got protein up, and then you're going to have an increase of opening pressure. So I would know that if I give you guys a patient, it looks like meningitis, and I tell you they have a leukocytosis, and their glucose is down, and their protein is up. I'm trying to walk the dog and tell you what's going on first. This is just a same thing we just talked about in a chart form that if you squint your eyes, you may be able to read. I can't see it, so maybe worth just losing that next time. So some findings, right? So post-mortem findings. This person, I'm assuming they didn't do well. We said it last time. It's post-mortem, right? So they did not do well, but you get loss of sulci, edema, and pus. Kind of hard to see, but by the positive arrow sign. So again, byproduct of bacteria, pus. They get swelling, loss of that sulci, definition there. Please remember headache, stiff neck, and fever, right? Headache, nuchal rigidity, fever. Headache, nuchal rigidity, fever. Got to rule it out. Don't memorize this, but know that there are different ways to treat this, right? So antibiotics, of course, it's going to be our priority. Don't delay it. Some antibiotics work best. You can see there your age 1 to 3 months. You can see AMP plus Rocephin. 3 months, 55 years, ceftriaxone, Rocephin. Rocephin kind of has the versatility. You can see it in there. Aseptic they have, immunocompromised, AMP. I don't even know, that's a 3rd or 4th generation cephalosporin, and then vancomycin as well. So I'll tell you, out of all this, what I want you to remember is Rocephin or ceftriaxone. If you don't know, you don't have a source, it's good because it crosses the blood-brain barrier. So if I give you this, the patient comes in, I'm walking the dog, I'm trying to tell you it's meningitis. So you do a physical exam and they have this. I want you guys to think of Neisseria meningitidis. This is a propitic rash. How do I find this? You expose your patient. So again, that's not me walking into the ER and I'm like, I have a headache. I put your neck down. I'm like, yes, that hurts. So like, naked, right? Get her naked. I'm like, oh my God. This patient comes in, they're obtunded, they're septic, right? Check everything. Check everything. Check under those intermembrane folds. You gotta check the skin. You're gonna find it. You gotta have a high index of suspicion for a source of infection. You gotta look everywhere. That's the job you're signing up for. 400 pounds, looking under those folds, get after it, right? Flip your patient. I've seen some wild stuff with my nursing home patients. You roll them and they've got like sacral debridement down to the bone. And you like look at it, I'm like, what is that? I'm like, oh, that's her bone. Neat, right? That's not a good outcome for your patient. Do not delay your treatment, right? So this is a medical emergency. You can see there, circle that for me. Goal to begin antibiotics here within 60 minutes of arrival to the ER. That's a lot of time, an hour. So I would tell you, like, usually it's gonna happen quicker than that, but that's our goal. 60 minutes at arrival, we wanna get antibiotics on board if we think this is meningitis. Typically what'll happen is they'll come in within 5 minutes, they'll call a sepsis alert, and you're probably gonna fire Rocephin anyways for unknown cause, unless it's glaringly obvious and you find something. But anyways, for the book, that's what they want to see. Okay? Blood cultures before or after antibiotics? Before, right? Why? So antibiotics aren't magic. You don't give them and they're like Lazarus. They stand up and walk away. But you want to get the best opportunity to culture something. So get them before, but don't freak out. Like sometimes, and again, this is from the mind of Chris, like if you're in there, and you ordered antibiotics and they administer them, and it's like a minute later, and you're like, oh crap, I didn't do blood cultures. Get your damn blood cultures. Don't be like, I'm toast. You can still get them, right? It didn't magically get up there and start beating the crap out of that bacteria. It's still in there. So. All right, viral meningitis, right? This is not reportable, but it's out there. You can see there, almost 100,000 cases a year nationally. You can see there, enterovirus by far leads the way. Circle that for me. That's greater than 85% of the cases. So we're thinking meningitis, we rule out the bacterial. I probably already gave them Rocephin. CSF comes back and I don't find my classic findings of bacterial meningitis. Could this be a viral meningitis? Absolutely, right? These folks present sick too. They're very sick. It's meningitis, an infection of the leptomeninges. This is not good. So, typical profile, you see a pleocytosis. You can get normal to high, slightly elevated protein concentration. This is your CSF findings. Normal glucose, so it's not up, there's no bacteria eating it. And then normal or mildly elevated opening pressure. So just contrast the differences between the two. But really, you're going to wait until you get that read back and take a look at what's going on from the lab. So, how do we treat a virus? Supportive care, symptomatically. So analgesics, antipyretics, antiemetics, fluids, electrolytes. You got to monitor that stuff. So, and again, You guys think, yay or nay, viral meningitis, you think they'll earn a trip in the hospital? Yeah, they're sick, right? And we know the viruses take 7 to 10 days to completely, if your immune system is working normally, completely run its course. So like day 3, 4, and 5 are pretty damn miserable for these folks. So admit it. Admit them for monitoring. That's fine. Outcomes, get it earlier the better, that should make sense, right? If there's an offending agent, we find it, we treat it supportively and or posture destroy with an antibiotic, they do better. So poor prognosis, elderly, so delay in treatment, delay in treatment, delay in treatment, so we can affect that one, I can't affect your age. If it's so far that they have neuro changes, focal signs and or stupor or coma or seizures, that's bad. It's a bad, usually indicates a bad outcome for the patients. We already talked, oh no, we didn't, I'm sorry, we talked viral meningitis. So encephalitis, that just totally black out. No, encephalitis is gonna be an infection of the brain tissue proper. This is most commonly viral. HSV, right? Varicella zoster, Epstein-Barr virus, those are a few. Enterovirus, arbovirus, just know that they're out there, okay? You guys remember playing infectious disease and figuring out what part of the world they're in, right? So everybody presents with headache, fever, and lethargy, right? But they rode a horse in a cave somewhere, and you're like, got your ass, right? Just do your history. Any recent travel outside the U.S. or in the U.S., any sick contacts, try to ask those questions. You're getting the thought of the practice of asking those questions. Okay. NCT, do we want to do that before or after an LP? Always before to rule out a bleed and or a mass, right? Anytime I stick a needle in there, I want to make sure there's no bleeding or a mass because we're going to create a vacuum and hurt your patient. So always before, please know that. Not for my test, for the test of life. If I impart only a few things on you, that's one of them. So you could get elevated ICP, obstructive hydrocephalus. You could have a mass effect, so you want to make sure we rule that out. MRI is more sensitive and specific. EEG, you might feed a few slowing. I'm not getting these, but we'll admit them and they may see that. CSF analysis, protein normal or slightly increased. Lymphocytes present because it's a lymphocytic, it's a viral infection. So again, just kind of tethering that, knowing your basic, what do we call that, clin lab and or anatomy, really what your leukocytes are doing. So, and then your glucose is going to be normal. That should make sense. All right, treatment, ABCDEs, right? So airway, breathing, circulation, deformity, everything else exposed. So we're going to make sure we go through that first, manage appropriately. If they need an airway, give them an airway. Fluids, electrolytes, nutrition, right? Trying to avoid secondary infection, manage an ICP, elevate the head, diuresis if you need to, mannitol, and then seizure precautions. So prophylaxis, Keppra to prevent a seizure. You may be asked to do that. I typically wait till I talk to the neurologist and see how they want to manage it. But all right, last one. You guys almost there? You guys are tapped out right now. I am too, believe it or not. You guys think I am? I could stay here all morning with you guys. Matter of fact, I'm going. This is the best part of my day by far. All right, sinus headaches or sinusitis. You're going to see this, yay or nay? Yeah, absolutely. How do I figure this out physical exam-wise? Yep. What are some other pertinent positives? Put your head down. So you got facial pain and pressure that come in with that, right? You tap, you look, ow, ow, ow. You're like, yeah, all right, cool. That in itself, I wouldn't say hang your hat on, but you start leaning forward, you get increased pressure. Transillumination, y'all talk about that? So I still do it. Some people think it's like witchcraft. I can't really transilluminate up here, but I'll hold the light here and look under, right? Sometimes you get obscuration of the light. You can see that's maybe secondary to, like, most likely it's going to be purulent drainage because it's thicker. What else? Anything else? Outside viral window, 7 to 10 days. Usually 7 to 10 days where like, yeah, you got an upper respiratory infection. Like, let's do some Sudafed, Mucinex, spray that nose, nasal rinse, Tylenol, Motrin, take some water, take some rest. If they're usually outside that, you maybe start thinking of a viral sinusitis. Let me just read this. They got nasal discharge, fever, sinus pain, tenderness, right? You can get a benign headache syndrome. Consider, you don't need this, but consider plain film CT or MRI. Actually, interestingly enough, like if you have a chronic sinusitis, you'll treat it, antibiotics, they get better, they come back, they still have the same thing, they get better. These patients are kind of tricky. If you're like, you know what, I gotta start thinking outside the box. Like maybe they need, and again, you guys learn about like fast or fundoscopic sinus surgery where they float the balloon and crack the sinuses. Did they talk about that one? So maybe they're a candidate for that. bottom line, where I'm going with this, long-winded, if you're gonna refer someone to ENT, they want a CT of the sinuses first. So if you try to do that within the military care system, they'll just deny it. But do your damn job, right? And there's some bylaws that say like, must have a CT non-con for sinuses, like just get in the habit of thinking about that, and they need that secondary intervention of floating a balloon up there. You guys can see that stuff on some of your social media feeds too. It's rowdy. That's a little different. Chiropractic, like cracking bones up here with balloons. Have you seen that? Nuts. It's a little different, but you'll do a FES, fundoscopic, endopic sinus surgery in bedside, which is pretty neat. They'll float a balloon up here, crack it, irrigate out. Now they have a better opening and they can drain that. So, all right, antibiotics and then surgery. We just talked about a lot. What else? What do we want to talk about? Let me just recap. You guys can recap this. So. I've talked about it. Whew, questions? Concerns, bitches, moans, Greg? Yeah.